Come on. Great. All right, Brady. We got about 3 minutes, so y'all have any questions? All right, I'm going to start back, y'all. It's 4 o'clock in my world, so sooner we get started, the better. Sooner we get done. So this is a review of what we've talked about so far. Excuse me. Changing the brain's communication highway, and this is kind of the short version of what I give my patients when I'm trying to explain what we've gone through already today. We've got alcohol and marijuana prescription auditory receptors, neurotransmitters with use happens kind of like this. A person experiences euphoria from the release of a dopamine excessive amounts when they drink or drug, and the brain records this pleasurable experience in a short-term memory. This was a good time. If the person begins to repeat the pleasurable experience, the dopamine becomes depleted. The brain attempts to stabilize the chemistry by using another set of chemicals, the endorphins, to reset the brain back to normal. But this attempt just creates a need for more of the drug, tolerance, withdrawal. The person continues to use, thinking that they can get back to normal. The brain activates a third set of chemicals, the dynorphins, and to keep the communication highway open. The dynorphins are responsible for many things in the brain. One of the most important is stress reduction created by intimate relationships, and that could be family, friends, church, etc. A long-term memory system is activated. A person continues to use, the dynorphins are depleted over time, making normal relationships less important, which is a part of the diagnostics, which is included in the criteria. As the depletion of the dynorphins continues, the brain begins to substitute the drug of abuse for the brain's natural dynorphin. The brain becomes hijacked using the drug of abuse as a primary relationship of importance instead of normal relationships in a person's life. This is a substance use disorder. Once the hijacking occurs, it is irreversible. Substance use disorders are chronic disease processes. So that's kind of how I've put all that together in a summation. So maybe that will be helpful to you. Again, the addicted brain, this is just another reinforcement. I'll get through this quickly. You have a stress, triggers the Miller Lite, makes me feel good, creates the craving in the pleasure brain, which becomes instinctual, automatic. It's unpredictable at times. Then it goes to, I want a beer, which is the actual end of the craving, and the judgment brain. And from there, the thinking brain takes over, the addicted brain, without the reinforcement issues in the prefrontal cortex of what treatment provides. Relapse most likely will occur. So there are 3 stages of addiction, according to Dr. Koob. There's binge intoxication, which stimulates and overstimulates the reward brain. At the same time, with the overstimulation and depletion of the reward brain, you have the withdrawal and negative affect that occurs as a result of the glutamate and GABA overstimulation and overproduction. It creates an anti-reward brain. That anti-reward brain then creates preoccupation, anticipation, and craving, which is what we understand as a substance use disorder, and an ongoing craving brain. It is the craving brain that has to be addressed in the treatment module, and the understanding of how you manage that through different behavioral changes and different processes. The key element of addiction is the development of negative emotional state during drug abstinence. The neurobiological basis of the negative emotional state derives from two sources: decreased reward circuitry function and increased anti-reward circuitry function. The anti-reward circuitry function recruited during the addiction process can be localized to the connection of the extended amygdala in the balance forebrain. And the amygdala is responsible for a couple of things: anger, fear, and what some people will identify is, why do individuals who suffer substance use disorder have extended resentment components? And we think maybe it is because of the diminishment of this extended amygdala. We're not real sure yet, but that is why there's so much anger, and fear behind the anger, or fear in front of the anger, is a major emotional trigger for the possibility of relapse. Neurochemical elements in the anti-reward brain system of the extended amygdala have been a focal point of the extrahypothalamic corticotropin releasing factor. This is the extended amygdala. Is what creates the stress moment that can lead back to a situation. So stress management is a huge deal when it comes to managing. Other transmitter system implicated in anti-reward response include norepinephrine, dynorphin, neuropeptide Y, nociceptive. Vulnerability of addiction involves multiple targets in both the reward and anti-reward brain system, but a common element is sensitization of the brain stress system. Dysregulation of the brain reward system, recruitment of the brain's anti-reward system are hypothesized to produce an allostatic emotional change that can lead to pathology. That's why we have the various levels of substance use disorders. Non-drug addictions may be hypothesized to activate similar allostatic mechanisms. Again, that is the mechanism and the relief of when we think behavioral addictions are similar to chemical addictions. Again, they are treatable, as we said before. So the longer a person can remain abstinent, the better chance the brain is to recover. When we look at the components, and we'll talk more about this tomorrow, the comprehensive drug addiction treatment, we have multiple ways and multiple things that has to be addressed according to the dynamics of the various levels of treatment. The pathology of substance use treatment, as we try to do, we try to, one, override the limbic system's basic drives in seeking experiences of reward and euphoria. And we do that through a cognitive mechanism of psychosocial therapies, 12-step program monitoring, contingency therapies. And we try to help the person increase and change decision-making, thinking, reasoning, and learning as a matter of cognitive behavioral approaches. And then, of course, we have medication interventions. Some are agonists, some antagonists that are also used, but it's a combination of both of those that seems to have the most effectiveness and efficacy. The recovery mechanism can reverse the depletion a day at a time. To recover the biological hijacking of the brain of the drugs of choice, the brain must be reestablished a human dynorphin experience. That's the beginning of the recovery process. To establish the recovery process, dynorphin reestablishment, human relationships are essential. And that is extremely important. The fabulous 5 elements of establishing these human recovery relationships are: don't drink or use, call a sponsor. I do this with mine every time I'm with them. I have them do a yellow 3x5 card. They physically write this down. They carry that card with them every day. When I ask them to see the card, they simply pull it out and read it to me in an effort to try to reinforce those 5 simple things. And so we got find and call a sponsor, find and go to a meeting, work the steps or similar spiritual program, repeat daily. And when I try to tell them, if a person follows the fabulous essentials the dynorphins begin to be restored. And as long as the process is in place, relapse and cravings can be avoided and diminished. Stop the process, the dynorphins are depleted, relapse and cravings can and do return. So pretty simple process. Again, ASAM, the book, which I have no interest in, it's through ASAM criteria. Some of you may have this. They have a placement criteria. This is actually the copy of the level 2. And what this is about is we have an early intervention service level 05, which is actually like a DUI school. This is something that some people are, more prone to want to do because it's the easiest thing. But it's not really for people who really have a substance-related disorder. Can be helpful for early intervention, but not. The other part about this is the opioid maintenance therapy, OMT, which is actually a level 1 category in an outpatient setting in ASAM. So for many years, treatment programs have separated OTPs, opioid treatment programs, from any other service. And what they didn't know, and I don't know if it's just due to design or due to ignorance, they're incorporated in the first level. So they should be an incorporated mechanism to be good. For many years, everybody believed in abstinence-based treatment, which means no medication whatsoever. We realized that was a mistake. We went to the psychotropics developed in the 90s and 2000s in the new decade and the new century. The approaches to treat co-occurring disorders. And now that we've got the overwhelming amount of opioids, some people are still looking at abstinence-based of whether or not they should be appropriately using buprenorphine, methadone, or, are not excluding those people and going into recovery residence and other things. And that is really a very detrimental. Even though these services are listed in medical criteria, there's ways to treat people and way to manage people. If that is given an appropriate effort. But not everybody who has an opioid disorder needs to be placed on OMT, but not everybody who goes into an abstinence-based program with opioid use disorder needs to be excluded from an OMT. That's one thing that I'm trying to help train lots of individuals. Can all these things be abused? Of course they can, but the thing about it is I want people to know it is incorporated into the level 1 treatment programs. Level 1 and level 2. Level 1 is an outpatient treatment. It can be abstinence-based or it can be OMT. Level 2 includes intensive outpatient. Level 2-5 is, of course, partial hospitalization. These have to do with the number of hours. Eddie, what is the role of Suboxone? We'll talk a lot about that tomorrow, Eddie. Suboxone is buprenorphine. It is a marvelous drug. It is used, I use it a lot for ambulatory detox. I've used it for long-term individuals who are been in opioid vomit for at least 5 years. It has a better efficacy from the standpoint of long-term use. I use methadone probably in about 10% of the individuals that may come in and qualify for OMT, but buprenorphine is good. Good and bad. Is it something that needs to be monitored? It does. Is it something that can be used long-term? I do not allow buprenorphine use unless there's an exception. There's always exception to these rules, longer than 12 months, mainly because we got to learn and see. But it's entirely up to the patient. When they go into an OMT, it's entirely up to the patient about what the role may be. If they follow the guidelines and the rules according to treatment team, then they can remain on a medication as long as they choose to desire. And that's not a question for the treatment team to answer. It's a mechanism of working with the patient to help them understand you might be able to step off of this and we may be able to do some other things with it. But from my end point, I'm very grateful for buprenorphine and buprenorphine and naloxone. I prefer the combination Suboxone instead of Subutex because of the naloxone included. So it's an important, very important drug. I use it for detox, for opioids, and works very well. And we'll see, down the road how it does. But there are many people, and I'll be the first to tell you, that will come in and they will seek a drug instead of abstinence-based. And if that's what they want to do, so be it. And then the programs have to decide. So what we did in our outpatient program, abstinence-based for 30 years. And last year we opened a office-based buprenorphine practice with a ASAM certified doc. And we've had about 70% of those individuals who came in initially on wanting only a medication who have moved from medication only to intensive outpatient. And that has been very helpful. And a lot of those people have been successful in removing buprenorphine and moving into a very healthy lifestyle otherwise. But there are some people who tried it, and because of multiple reasons, we felt that it was necessary for them to return. And so we have about 10%, mainly because of the anhedonic process that occurs with long-term use of opioids in the brain. It helps offset the depression and anhedonia from the opioid use disorder. And these people function very well. In fact, a lot of them function much better. We tried traditional psychotropic meds, but found that they just did not work as well. And it seemed to help a great deal managing not only the depression, I think that may be drug induced, or it may have been present and was worsened as a result of drug use, and put them into a world that they can really function well. The problem is the stigma. Stigma when you put people into OTMs, OMTs, it's the stigma of both the recovering community as well as the people out on the streets. You know, it's got to have something, blah, 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 blah. So I've had to do a good bit of intervention and sometimes some pretty rough discussions with people that are in the recovery community about the issue of Suboxone with individuals that are coming into 12-step meetings. And it is a struggle. It's a struggle. And so you really have to prepare people, because a lot of people will come in and get a medication and not go to support groups. We want them to get a medication, be able to go to support groups. And with that, they may make a decision that they may want to come off of medication at some point with some suggestion from the treatment folks. But it's a complicated issue. But right now, like I say, in Georgia, we got 700,000 individuals that have substance use disorder. Probably 300,000-400,000 of those have opioid disorders. And if I added all the beds together, we probably have less than 2,000 chairs of beds to put any of them in. So without some sort of stabilization, that's what I look at as buprenorphine, these people may go out there and die. And as I tell all of my students, my goal and what I do as a clinician is to make sure they live till tomorrow. I want to make sure they live to tomorrow so that we can do something about it, if it be through from a behavioral standpoint, a medication standpoint, or both. So does that help you? Okay. Again, as we look at this criteria, then you go to level 3, which is your residential. And it depends on the level of direct level of clinical management. And that is one of the things that we look at. Of course, that's a double whammy there. Level 3-5 is residential with more intense supervision. Level 7 is the most closely supervised. And of course, every time you go up to a level, there's more expense. And of course, level 4 is stabilization. They call it medically managed intensive inpatient, but that's basically what I call crisis management. And we have a lot of that in the inpatient detox centers that are all over the country now. So that's ASAM level. And that's it for that. All right, let me see if I can get out of this. And there's your references. Yay. All right, let me see if I can get out of here. All right, let me go back and see if we can do some. Any questions about that? Okay. All right, very good. Thank you. Thank you. Thank you. All right, let's see if we can talk about a little alcohol. I'm going to try to get through as many of these classifications as we can. We got a good bit of time, so maybe we'll get through all of them. I hope we will. All right, let's see. Here we go. So let's talk about alcohol. It's still number 1 on the hit parade. I'm going to talk about the background. I'm going to talk about the kinetics. I'm going to talk about pharmacodynamics, some effects, some of the issues of abuse and other things, and we will go there. So here's your self-assessment question 11. They always want you to have self-assessment. So alcohol is considered a highly addicting drug. True or false? A or B? Mm-hmm. B, 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 B. B, 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 A, B, B, B. All right. A, all right, Eddie. All right. Well, y'all were listening to me. It is the least addicting drug that we have. It is an addicting substance, but it is not the most, or it is not considered. The addiction liability of alcohol is about 1 to 5 in adults. If we look at the addiction liability of injectable heroin, it's 1 to 2. If we looked at the addiction liability of crack cocaine, it's 1 to 1. Alcohol actually is one of the least addicting, even though it's a legal substance and we have a larger number of individuals consuming it, it is not one that is considered highly addicting. It's a low potency, and the reason it's low potency is because it's water soluble. Ethanol, ethyl alcohol is what we call and what is sold. And in the US, standard drink by weight volume is 14 grams of ethanol per ounce. So when we calculate the average percentages of alcohol in beer, wine, and liquor, it's 5, 12, and 40. We have other forms of alcohol which people do drink, but they're toxic. And so we have isopropyl and others. And most people, when they get, well, all people, when they get a DUI, get blood alcohol content, which is the percentage of alcohol in someone's blood. So what it is, most of you have probably seen moonshiners or may have watched moonshiners. Eddie says, is the addiction rate higher in certain population gender? Yes, Eddie, it is. It can be. Women are more susceptible to the effects of alcohol. We're going to talk a little bit about that. The Native American population has got the highest genetic risk of alcoholism within their male population, about 60%, they say. So yes, it depends on gender and definitely depends on certain types of population. So when you watch moonshiners, they go through both processes. They have a fermentation process, which is typically what we use for beer and wine, where you add sugar and water in the air, put yeast. The yeast eats the sugar and excretes, and for the kindest of words, excretes ethanol, and it starts to bubble, and then also CO2. And what happens is, as they excrete ethanol, they also excrete CO2, and eventually when you get a concentration of CO2, about 10 to 15%, the yeast die, and that's where the amount of alcohol produced in those spirits maximizes. So what we do with that is, and basically what they do in the moonshining world or in the distillation world, they will take that process and then they will simply cook it, and they will put it under pressure and they will distill it, and they remove the water through the process, and it will increase alcohol content. And from there we get all the different types of brandies and wine, distilled wines and whiskeys, etc. And you can make it from various things, vodka from potatoes, various grains will make various whiskeys, etc. So we have that. When we look at the overall, and when we looked at this, and it's been a year or so ago when we looked at it, and Caitlin was one of my research assistants, which you put together, about 18 million adult Americans are considered with alcohol use disorder. We have about 80+% at ages 12 and other report lifetime use of alcohol. About 67% report annual use of alcohol. And then we have about 50%, a little over, report monthly use of alcohol. So it is at least the use on some sort of regular basis is very common in our culture. If we look at the kinetics, and that's basically the action of drugs with the body, drug the body, so to speak, which can be, in many respects, be envisioned more accurately as actions of the body on administered drugs. So when we look at drug absorption, distribution mechanism, metabolism, and excretion, which y'all have had in your pharmacology and pathophys courses, We also want to look at onset of action, duration of effects, biotransformation, and effects of routes of excretion of the metabolites. And so we'll check that out. So it is hydrophobic and hydrophilic, which means it is soluble in water and in many solvents. It is in pharmacy our greatest solvent. It will dissolve most medications depending on concentration. That's why a lot of your cough syrups, vitamin tonics, liquid vitamins, and other things, even topicals, are dissolved in either ethanol or isopropyl alcohol or some form of alcohol because of that reason. And we have the different structures, and we won't really manage to go into that, but we do have that capability from that standpoint. We have an OH, hydrogen bonding, which creates a lot of solubility with lots of different other organic and inorganic compounds. Now, when we look at the kinetics, it's an oral product. It's based on total body water. So you've got the body composition, as we mentioned earlier, women have a lower proportion of total body water. So their effect of alcohol, it takes less to get more effect. Absorption is usually through the duodenum and the small intestine. About 20% though of alcohol passes directly through the stomach. But the rate can depend on food, the amount of alcohol and the concentration, how much you drink at a time. And also it has first pass metabolism, means aspirin increases the absorption by affecting first pass metabolism. So alcohol can be, has major drug-to-drug interactions with lots of prescription and over-the-counter medication, some increasing the rate of metabolism. The rate of metabolism in the liver, though, is fairly standard, 10 to 14 grams per hour. Now, roughly put, if you look at 14 grams per ounce, that's about an ounce per hour. So if you drink 12 ounces and consume 12, and this is total, 12 ounces of alcohol, and that could be, a quart of liquor, it could be a case of beer or whatever it may be. How long is it going to take you to metabolize that alcohol? If you're metabolizing an ounce, and it's a standard rate, an ounce per hour. If you consume 12 ounces and it takes you, and the liver's metabolizing 1 ounce per hour, how many hours does it take? It takes 12, that's correct. So most people don't understand that it's a very slow process. So people get intoxicated and they may have that experience for 3, 5, 6 hours under the influence. They may still be drinking, even though if they go to sleep or go to bed, when they wake up, they're still metabolizing that. And the thing that most people don't understand, that still impacts your response in how you drive and how you think. It takes anywhere from 96 to 144 hours for the average drinking bout to recover from it. So y'all figure that up, 24 hours. And how many days? It takes anywhere from 3 to 6 days for a hard night's drinking to fully recover, not only from the metabolism, but also to clear the central nervous system. So 95% of it is metabolized by the enzyme of alcohol hydrogenase. It breaks alcohol into acetaldehyde, and acetaldehyde, of course, is what brings about the side effects in your hangover. And from that, aldehyde dehydrogenase breaks it down to acetic acid, CO2, and water. That's why you can smell it on people. They can sweat it out. Of course, they can urinate it out, but also they breathe it out. And so you have that smell as a result. And again, this is 1 ounce per hour, about 1 ounce per hour. And so you can see where it has that kind of situation. Now, we do have some genetic variation in the metabolized enzyme. So you do have alcohol dehydrogenase, and they have discovered there's at least 5 classes of polymorphism that affects these 2 enzymes. And so what happens is each subtype is associated with different ethnicity. And so 15% of African Americans have the alteration of AH23, which means they have a 25% higher metabolic rate. What does that mean? They metabolize it instead of 1 ounce per hour. They have metabolized it at 1.25 ounces per hour. So that means they can consume more and metabolize it faster. It also could have something to do with the Asian population, which has 85% prevalence, which means they have a slower rate. And what happens is when they drink too much alcohol, they will start breaking out into a flushing effect, very similar to what antabuse does to normal folks. And this is a process that we think may prevent a large majority of that population from consuming more alcohol because of that type of reaction. We also have alanine dehydrogenase polymorphisms. And so we have the alteration. And as we talked about, when you have that, you have the flushing response, which is very common in Asian, but also we have it in other cultures that we've discovered. Some Norwegians have it. We have some in certain side of Middle Eastern individuals. So the thing about it is it's not just located within the Asian population, even though it seems to be, has a high prevalence depending on various factors. So you have that. And the dynamics, basically it's the effects of the drugs on the body or the microorganisms, parasites within on the body, the mechanism of drug action, and the relationship between the drug and the concentration. So the dynamics is what does it do and how does it work? Well, it's a depressant. You know, drink, what happens when the first drink or so, within the first ounce and a half, it releases the dynorphins, dopamine. That's a stimulant. So you get that woohoo, that stimulant effect. But the thing about it is a depressant. So it's messy. It has a lot of diverse actions in the brain. It does create euphoria, impaired thought processes, decreased mechanical efficiency, reduced anxiety, disinhibition. It has myopia, which is compulsive, and it's compulsive activity, spontaneity, lack of forethought. And it also, all of these things are dose dependent on various factors. It does excite people because GABA is an inhibitory neurotransmitter. It's responsible for the sedation that occurs in a lot of people and also the reduced anxiety. A lot of people use alcohol to reduce anxiety of various types of situations. You also glutamate inhibition. So glutamate's excitatory neurotransmitter. It blocks the NMDA receptor. And what this does, it creates the cognitive impairment. It also kind of opens up the prefrontal cortex to disinhibition. And also it's part of the responsibility for the types of withdrawals we have. It also affects the opioid receptors, as we talked about. It inhibits GABA neurons, which increases dopamine. So we get stimulated in the beginning. It does bring us about euphoric effects. It does activate the opioid peptide system. So it does activate initially the endorphins and dynorphins. So guess what? You become 9 foot tall and bulletproof. People fall, they break things, they have accidents, and they never feel any pain while they're under the influence as a result of the activation of the opioid peptide system. And then it's responsible for the reinforcing and adversive effects, mu and kappa receptors that create the cravings as a result of an alcohol use disorder. Mesocortical limbic system, it's in the VTA, nucleus accumbens, prefrontal cortex. It's an activation, causes dopamine, and that dopamine creates the release of the endorphins, causes reinforcement, pleasure, and there we go. It's a very reinforcing drug from that standpoint. That's why people like it. Now, if we look at the neurosystem and see all the different components, now we also see all the different uses that people use ethyl alcohol for. It does the enkephalin and dynorphin, so that brings about pain or reduces pain. It stimulates the mu receptors, which brings about analgesia and euphoria. It stimulates the dopamine neuron, which creates euphoria. And also it blocks and impairs the GABAergic which means it makes it less anxious. So no pain, no anxiety, and euphoria. It makes it a perfect drug for people to have fun with. Let's put it that way. Let's talk about the effects. Well, BAC effects are, here's a table. I won't regurgitate this. Most of you may be familiar with this or seen this. If you look at the average 12-ounce beer in a 150-pound male will elevate the blood alcohol by 0.02. In women, it's 0.03. So if you look at 0.02 up there at the top, slight changes in feelings, sense of warmth and well-being. In women, if it's a 0.3, they would have feelings of relaxation, exhilaration, happiness. You may have the skin. The impairment in the motor skills is quite obvious. The first impairment that you have in alcohol consumption, which people may or may not know, is eyes. You lose your peripheral vision. In fact, you can have 3 beers and lose about 30% of your peripheral vision, which is the vision that you see from side to side. And that may not seem like a big deal unless you're driving. And what we're finding out, and if you look at the National Transportation Administration's fatality scores, and you look at accidents involving alcohol, over 60% of those accidents, fatal accidents, occur from the vehicle hitting something from the side, not from the front or the back. They just didn't have wide enough range to possibly see it. It also slows that impairment down about 15%. So the moving towards the braking system extends 60 miles an hour, can extend the braking at least 45 feet. Now, that doesn't seem like a lot unless you drive in Metro Atlanta. If you drive in Metro Atlanta, 45 feet is enormous in between cars. People just don't do that. They're on top of you within 10 feet or less. And if you've had, 1, 2, possibly 3 beers and you've got 45 feet difference, it's quite upsetting to most people when they find that out. Most laws in most states say that a DUI comes at 0.08. And that's the thing about it is. Now, in Georgia, if you violate a moving vehicle law, you can have a DUI at 0.05. If there's another involvement, and it can be, and we've had them stop all the time with texting on the phone, doing anything that involves a moving vehicle, and the law is such that, and there's a consumption, you can actually have a DUI charge at 0.05. Even though it's hard to prove in the courts here, they usually have it for, will move it down to reckless driving or some sort of, and don't have DUI. But if you see that DUI at 0.08, 0.9, that's about 4 beers within an hour for most 150-pound guys. And the bigger you are, the longer it takes. But I'm just saying, most people I know that are normal will drink 1 or 2 within an hour, and they don't drive because of that issue. But anyway, that's your blood alcohol effects. As people increase the consumption, I had a case where a student died and his blood alcohol was 0.35. And people want to know, how does that happen? Well, one of the things that happens is that people will drink and take the benzodiazepines. And what happens with benzodiazepine as an alcohol, of course, there's a synergistic effect where 1 + 1 = 3. But also, what most people don't know, there's a natural, I think, a survival process. Alcohol, as we know it, is pretty acidic. And so if you drink large quantities of alcohol and you add it to an already acidic environment, such as the stomach, you will stimulate what we call the gag reflex. And when that gag reflex goes stimulate, we will throw up excess alcohol, which saves a lot of people, and they don't know this, saves a lot of people from going into alcohol poisoning. And it's a protective mechanism. It's a good thing. As long as people don't consume cannabis or benzodiazepines or something. both of those chemicals can impair or block the gag reflex. And if you continue to consume alcohol, and that's what this case was about, this guy happened to be they had a kind of a farm party, and he'd taken some Xanax, stopped his gag reflex, and consumed too much alcohol, and he died from alcohol poisoning. So you can see at 0.3, at 0.4, and at 0.45, you actually have LD50. That means half of the population who would ever get to that amount would actually probably not survive. So that is your blood alcohols as we see it. And then you have the changes where you have that stimulant effect. I said it's a very short acting as a result of a dopamine surge where you're well-being and energized and talkative, and that's your first drink or two. Woohoo, woohoo. And then if you stop that and then you kind of calm down, and people, that's what normal drinking is about, one or two, and go from there. But if you continue, you can go into the other side of the curve where you get sedative effects and you get sluggish and irritable, and you can actually have some slowing cognitively. Your acute effects is respiration is dose dependent. It slows respiration as a rule because it is a depressant. Not life-threatening unless you have a combination of opioids or high-dose cannabis or high-dose benzos, where there could be some significant respiratory depression. Cardiovascular, it dilates the blood vessels, and of course, the longer people do, it does have a high propensity to increase and create hypertension. And that will lead to both heart disease and also the issue of strokes. We can have various types of blackouts, and that can occur at any dose. It varies from person to person and varies to amount, where there's a complete blackout, they don't remember anything, even if you had a video on them, or there's what we call that's an M-block blackout. Or you have partial amnesia, where you actually black out. You don't remember people. You start asking questions about what happened, and people start reminding you what happened, and then you start recalling it. Pretty significant with high dose, and it can occur to most anybody, even though they used to consider blackouts very common amongst people who had alcohol use disorder, and that is still true. Hangover, as I told you, has to do with the release of acetaldehyde. Depends on how much, how long, how tolerant, etc. And also sleep, it can induce sleep, even though it does suppress REM sleep. So you sleep, but you don't get a whole lot of rest from that. Respiration, we talked about that again. Pain, decreased sensitivity. So about 4 beers or 5 shots in the wind, you're not going to feel a whole lot of pain because you do decrease the sensitivity. You do impair vision, as I said. You also impair taste. In the beginning, you enhance taste. That's why people like to have a small glass of wine before dinner. Smell can be blocked. Your reaction times can be very impaired from the driving standpoint, and multitasking abilities is impaired. The aggression piece is still not understood. The latest I heard about that, and the aggression can be against others or against oneself. We think it has to do with the triggering mechanism inside of the extended amygdala, where there's an issue with overstimulation, and certain people get overly aggressive and violent, whereas other people take it internally and they're more likely to harm themselves. And we do know that there's a high number of suicides that are committed under the influence. Sexual response, both male and female, they're negative response depending on dose. And so it can create lack of potency in males, libido in males, libido in females, and orgasmic response in both. Long term, again, the longer you drink it, the more likely you're becoming tolerant to it. There's 3 phases. You can have the hourly shakes, sweats, headache, weakness, nausea. As that gets worse within a 24-hour period, and this is kind of progression, you can begin to experience grand mal seizures. And once you've had a history of grand mal seizures, as I just finished the lab covering delirium tremens for my physician, my fourth year physicians and my fourth year pharmacy students, you're going to have to really evaluate once that seizure has been managed within the next 4 days. You're going to have to really look for delirium tremens. Now, delirium tremens or DTs shows severe agitation, disorientation, hallucinogens, severe tachycardia. A lot of people will die from the tach itself. We have now more better vent tach stabilization drugs, and so not as many die as they used to, but you can have that serious type of tachycardia with in delirium tremens. And so we have to be aware. About 15% of people who develop delirium tremens nationally will die as a result, directly or indirectly, of that. So it's pretty serious from that standpoint. The post-acute withdrawal syndrome is for people that are in recovery. That syndrome can last anywhere from 3 to 6 months once they begin to start their abstinence. But depending on their length of drinking, their age, et cetera, it can last up to 24 months after the start. Symptoms of a post-acute withdrawal, which are more behavioral than they are physical, is poor problem solving, clouded thought processes, overreacting, numbness emotionally, your sleep problems, poor memory, and poor stress coping. I think if any of y'all are in any type of practice where you're dealing with long-term or early recovering individuals from substance use disorders, this is probably what you're going to be managing a lot of as a result of some of this long-term, especially when it comes to the depressants, including alcohol. Wernicke's disease is due to a thiamine deficiency after long-term drinking. Of course, being B complexes, being water soluble, they're depleted pretty rapidly as a result of diuresis from the extensive use of alcohol. And you will see it, the confusion, staggering, abnormal eye movements, memory impairment, and it's reversible. Basically, that's why they will give them a shot of B12, or they'll give them B complex as a result, usually in stabilization units, if they know there's a history of that, in order to reverse Wernicke's. Korsakoff syndrome is a more serious and is irreversible. It's kind of an alcohol-induced dementia. It has to do with memory impairment, confusion, confabulation. So the thing about it is we have both of these as a result of long-term use and significant brain damage. The biggest problem that we have with alcohol in most people is fatty livers. That's the first stage that leads to cirrhotic livers, but usually the fatty liver is where the liver by itself does not contain any fat. And because of the mechanism of the high energy that is released in the metabolism repeatedly and very rapidly, as I told you, 1 ounce per hour, the liver begins to have to store this excess fat in the cells in the liver. So what happens is they develop a fatty liver. So that liver can expand in size to 15, possibly 20% bigger than it normally should be. That can lead to alcoholic hepatitis. But the beer belly that a lot of people know is, if you look at a lot of people who are drinking a lot of alcohol, especially beer or wine or whatever, you will see that the bellies are extended. It looks like there's a belly. Well, that's not the belly. That's not due to fat. That's due to the liver overextending itself over the stomach, especially if it's hard and it's got a spongy feel to it. It's pretty interesting to watch that. If they develop cirrhosis, is where those fat cells harden and create areas of depletion of cell function. You have about 50% of people have a 5-year mortality rate, which is pretty significant. We have new drugs now, and with the management of liver diseases as we have them, it's at 15%, Maribel, from DTs currently. About 15% who develop DTs die from them. You're welcome. The hormonal effects is also significant. In men, it literally over time will shrink the testicle. It will the prostate. It will also affect and increase feminization. So you increase testosterone, increase the estrogen, and so you can have some breast development as a result. Impotency is very common amongst long-term males of alcohol, regardless of age. And for women, it suppresses uterine contractions and milk ejection. So fertilization and other things, and if they're pregnant and happen to be involved in alcohol, the pregnancy itself can be very difficult as well as the delivery. So it is something that you've got to be aware of. So what do we use it for? Well, peak use is between the ages of 18 to 25 in this country. Males, usually Caucasians, smokers, as we see it. And again, we see this high number of individuals from this age. This was back about 3 years ago, 79,000 annually contribute. We have about 85 to 89,000 now that die. It is the one of the leading lifestyle causes of death in this country. The current cost would be estimated over $300 billion. It is a huge problem still. If we look at the causes of death, and this was a comparative study that we found back, one was 90 and one was 2000, a decade, and I'm sure they've got some since then. But as you look at 90s, and the 90s were kind of the heyday, tobacco was 400,000, alcohol 100,000, firearms 35,000, illicit drugs was 20,000, okay? And then in 2000, we had 435,000 die from tobacco. We had about 85,000 die from alcohol. The poor diet and physical activity is usually due to cardiac disease, cardiac-induced diseases. So you're about 400,000, which that number is now up to 600,000. The interesting thing is when we look at illicit drug use, we're now losing about 40,000 people to illicit drugs. So you see where the changes have been as it relates to drugs of use. Now, analgesics, and this was again another study about 6 years ago, that you have 65% report use, analgesics were 2% numbers of people. But that is when, and I use this graph here, when the pharmaceutical industry will not allow us to look at populations within medicine. And so the thing about it is, when we finally started to peel that onion back, we didn't have 3.6 million, we had 26 million. And we have a huge number. In fact, I just read a statistic for the state of Alabama where they still are giving out more opioid prescriptions. They're giving out about 97 scripts per 100 population. In other words, they still, in the medical world over there, and I've been over there several times trying to educate them to the appropriate use of opioids. But the thing about it is the opioids are still a major problem as we see it is here. So again, alcohol being a contributing component to that. So what is use? Any use of drug that causes physical, psychological, legal, or social harm to an individual or others affected by the drug or user's behavior. So these are definitions from the National Institute. So these are, and I'm not going to go over this. This is an old DSM-4, so I'm going to eliminate that. You don't have to talk about that. DSM-5 we've talked about. So this is the new category. I actually still have people using DSM-4 TR. But the thing about it is, I should have taken those slides out before. But anyway, here's your DSM-5. How long for the dependents? Well, again, some people, this was an example of one state, an average 16 ounces of whiskey every day for 2 to 3 weeks will cause physical dependence. In other words, if you drink every day for 2 to 3 weeks, and 16 ounces is a large amount of alcohol, you could create tolerance for withdrawal. And so people want to know, well, how long does it take? Is it one of those things we do? Well, tolerance, you can have decreased effect of the drug with prolonged exposure, acute decreased effect of the drug within a single use or exposure, chronic decreased effect over multiple uses or exposure. So the thing about it is it takes less and less of the drink to have the same effect. If we want to look at alcoholism and we look at, again, genetics, they have identified basically 2 types. And I would star this slide. I like this slide, actually. Type 1 are genetically and environmentally induced. In other words, people drink a lot as a result of high dose, or they have alcoholic genetic combined. And this is kind of what I call the adult onset. type, which means they don't start drinking until 18, 19 years old. It affects both men and women, so it's not gender specific. It has an onset, and this is the disease of about age 25 when we begin to see problems. They start drinking about 18, but they don't start really having significant problems about age 25 as a rule. And part of it, and most of it, is due to loss of control over drinking. In other words, when they start drinking, they begin to lose control over their family life or their work life or something along that line. And often they're drinking to relieve anxiety. Type 2, which is a much more malignant form, according to most of the researchers that I have talked with over the years. It's genetic. It's predominantly male, father to son. It can come from grandfather, father to son. It does skip generations. Their onset is usually around 14 or 15, but it's before 25. But a lot of them are adolescents. And once they start, the interesting thing about this type, once they start, they develop very quickly an inability to abstain. And they're not drinking to relieve anxiety or depression. They're simply drinking to feel euphoria. So you got type 1. We've actually developed a type 3 that is predominantly very similar to type 2, but it's predominantly female. So, but these women look different in that they also have prescription drugs on board because they also have anxiety, they have menstrual and conception problems, they have headaches and other things. And so they go to a lot of doctors and do a lot of doctor shopping on top of their alcohol. So that's, again, the thing that they're developing. So you actually, these are the two types that have been well identified in the literature. So if we look at some of the literature that we talk about, there are 5 types, and this is just for your information. You have a remorseful, resolute, no decision to stop one. You have a one that's unwilling to admit any kind of problem. You've got one that believes that he or she can drink again after a period of abstinence. You have one that we've described many years as being manic depressive, bipolar, and a lot of bipolars do use alcohol to manage their bipolar disease. And then there's people, which are a large percentage, and these are some of the ones that I will tell you maybe fall into that genetic alcoholic type 1. They're normal except for an alcohol problem. So they have a fairly normal life except for that particular problem. So what do we do with treatment? We talked about it. You've got natural recovery. People just go and stop drinking. They estimate about 10% of those people identified can do that. They get involved with a business, or they get involved with the religion or something, and they don't go to treatment. Self-help groups, a lot of people go, but really the ones that stay, about 20% of people who experience self-help groups, the latest recovery, stay with it. And so the self-help groups are very effective, but a smaller percentage of individuals don't. Professional treatment, again, as I told you earlier, and this is not specific to alcohol, we have a very low percentage of individuals who need services, ever seek services. So again, you have a lower percentage, but there is professional treatment. And you have the different models. You have a faith-based model, which is, in the original faith-based model said it was a lack of religion, and so you have to get more religious. And some people believe that, and some people do well with that, actually. You have the disease model that we've discussed, which is actually probably the more workable model that we've discovered. And since then, the research has indicated truly about the disease processes. A biological deficiency of some kind. This is where people talk about the other mental disorders, where people use alcohol to manage and stabilize that disorder. Social learning disorder is where you're exposed to people in your peer group and they teach you this. Social cultural have to do with the types of culture that you may come from. And of course, the model of treatment that most people use, the biopsychosocial model, which is a combination of several of these, as we've mentioned, and we'll talk more about that tomorrow. Again, this is the model of looking at problem recognition. Some people go to self-help groups, some quit on their own. Some seek professional treatment through assessments. There's a treatment plan, goals specific, and then they would go to the outcome, relapse occurs, and they can start all over. But that's kind of the gist of where they go. The time for change, again, the stages of change, which y'all are all familiar with: pre-contemplation, contemplation, preparation, action, and maintenance. Again, that is one of the things that we look at. Most people come in to treatment in a pre-contemplated situation where they do not think or recognize the need to change, or there's no active consideration of changing. Treatment, what we know about treatment, places them in a contemplation level, and if they're exposed to that long enough, theoretically, then they will move towards the preparation level, or they may go back to pre-contemplation where relapse occurs, and as a result of that relapse, they will come back better prepared to do whatever they need to do in order to maintain their abstinence. But that's a pretty interesting model, at least from my standpoint, as we see that. Alcoholics Anonymous is one of the 12-step group, original 12-step group, founded in 35, requires maintenance of members. Fellowship among members is important. There are many other types of recovery dynamics now in this country. It's estimated now about 2 million Americans use AA or some other mutual help group in order to stay in recovery. And it's difficult to study. There are some recent studies, but I haven't seen it. Yes, Angela, you can be a combination. Yes, you can be a combination. Type 1, type 2. A lot of people are. Eddie, does abstinence repair fatty liver? Yes. Your liver will repair within 12 months, depending on how severe the liver is. And that is something that I want to tell people, is that you do recover from the liver stem. Liver is a very resistant organ. It's very difficult to kill a liver. The thing that kills liver is Hep C. And now we got new medications for Hep C. I've got a lot of people doing well on Hep C meds, but that is where, again, IV use and other things can contribute to the damage of the liver, as we'll talk about it. Here's your 12 steps for those that may or may not be interested. Motivational enhancement therapy, again, is another approach that has been very successful. Guides individuals through the stages of change by expressing empathy, developing discrepancy, avoid argumentation, role resistance, and support self-efficiency. Reinforcement-based, the community reinforcement, the environment makes abstinence more reinforcing than alcohol. That's why I told you, I think the dynorphins is a part of that recovery process, and I think this theory behind the behavior is the reason why. It develops alternative sources of reinforcement, and it can be sought through therapy, marital therapy, social counseling, and other types of approaches. Has very efficacious compared to standard treatment. I like community reinforcement, and that's why we see a lot of CARES individuals in recovering communities. People are in recovery, they go through a short training period, and they turn into addiction coaches, and they are hooked up with individuals into one-on-one. It helps them overcome that. We also have contingency management, which helps targets individuals. Community reinforcement, we talked about that. FDA approved drugs and abuse, very adversive. You'll have severe side effects if you drink on top of it. Most people don't find it very effective. I only recommend abuse for people who want it and who are interested in it. Usually people who've relapsed several times and they can, and if they want to understand the maintenance of it, this is very effective, but it is available. Naltrexone is a mu opioid receptor antagonist, works very well. It's moderately effective. Campril or Campsolate is FDA approved. The only problem about it is you have to take it 3 times a day. It has efficacy of about 40% for people who can take it. I know it's break time. I know it is. I'm trying to get through this and we're done. All right, let's take a break. We're going to come back and talk about cannabis, okay? So we're going to take a 5-minute break and we'll be done. All right. I'm going to set these slides up and I'll be right back. Okay, everybody, y'all ready? All right, let's talk about the big boy here. This is marijuana. I've been traveling the country over the last 2 years, training physicians to appropriate use of medical cannabinoids, including about, I guess I trained almost 3,000 oncologists. So I've incorporated some of that information in this talk, knowing that some of you are in prescribing states, but I'm going to give you some information that y'all may or may not know that may be helpful at some point. So I think we're going to get through this. Colorado, definitely, Eddie. Yeah, I've been to Colorado many times, had in fact worked with the transportation, public safety. We were trying to evaluate how to evaluate DUIs as a result of cannabis. This was about 3 years ago. And so it's a difficult, it's been difficult trying to manage the science with the legislation. So, but anyway, and I've talked to several physicians out there in Colorado who have done very well in doing what they need to do as far as working with folks who want to use various types of cannabis products. And so anyway, we'll see what we have here, and maybe this will be somewhat insightful to you. It is a huge, as well as yeah, that's right. It's very complicated legally. See, I deal with death cases, y'all, and also I deal with a lot of malpractice. I don't take a lot of malpractice, but the 2 malpractice cases have to do with the current cannabis products. One didn't contain any CBD, was one. The other one contained too much THC, and we had a utility worker, as a result of that, who was told by the practitioner that it was a CBD product, 100%, and there's no such animal. Had THC, showed positive, even though on the screen it showed, and when they did a confirmation, but it's still, and so make a long story short, he lost his job. And so it can be extremely difficult. And it is it's going to be a big, and I'm telling all of my practitioners, including you guys, that the more you know about this, the better you are to prepare to educate your clients, your patients on the ins and outs. Whether or not they take your advice, that's one thing. But anyway, we're going to see what we can do. But let's see what we got here. All right, so we're going to talk about marijuana background, kinetics, dynamics, effects, use, treatment, and then we're going to talk about, in between, we're going to talk about medical marijuana, which is huge. It's kind of what Eddie was talking about. So the background is, and this is what I ask y'all, and as being prescribers, are going to be future prescribers, and where this law goes, and we'll talk more about that in a minute. I want to see, and y'all can answer some of this for me while we go down here. This would be a great, this would not be anything I'm grading. I'm just saying, I ask all of my practitioners, my physicians and pharmacists and psychologists and other folks who are going to be in the world that they have some prescriptive authority, these questions. So my question is, what are the benefits of marijuana? Give me some benefits of marijuana. Pain, okay, Eddie. Pain management, glaucoma, sleep, appetite, anxiety, okay. Appetite increase with cancer, absolutely. Reduce seizure threshold. Pain is the main, yeah, okay. And also probably some alternative meds that we don't have available to us at the moment, right? Especially, in the world of seizure disorder, especially the severe seizure disorders that we're dealing with. All right. Is marijuana a medicine? Nausea and vomiting. Manage mood, yeah. Yes, maybe, no, yes. All right. No, can be. CBD, as much as any other substance, depends on use. It's interesting. See, there's a definition of a medicine, y'all, that's listed by the FDA. And y'all are going to be prescribers. So what I'm going to do for you, And I want y'all go to the FDA website and look at it, and it will tell you what a medicine is. So y'all may do that tonight, do it tomorrow, do it next week. But I'm saying, does it qualify as a medicine? I'm going to explain this to you in the regulation in just a minute. That's why I asked this question. What are the appropriate doses for medical THC? How about CBD oil? How about CBD edibles? Don't know, do you? Well, all right. Another good question, right? We need to have some answers. Y'all want me? Well, you need to know therapeutic toxin levels. True. Isn't the problem there isn't much regulation. I'm going to talk about the regulations just a second, Joy. Nor do they know how this will affect people in the future. I thought MDS knew. Does marijuana have beneficial components to treat incurable chronic diseases? No, not cure. Don't think so. Uncertain. Should leaf marijuana be legalized? If so, how should marijuana be regulated? Well, it is legal in many states in various forms. And each state seems to have a different perspective of what should happen to it. And we're going to talk about a little bit about that in a minute. So going on, if I was to give you a test, I'd want you to give me list 5 adverse drug effects of THC. I'd want you to list 5: paranoia, amotivation, depression, okay? Psychosis, anxiety, okay? Depression, good. What is the primary adverse drug effect of THC? Addiction definitely can be one, but memory loss. It's memory loss and anxiety. Okay, that's 2 of the main ones. All right, let's list 5 adverse drug effects of CBD. Seeing how that's the hot topic. You know, it's non-psychoactive according to the theory. What are some side effects of CBD? Okay, all right, I got you. Should marijuana be a prescription drug or should it be over the counter? RX, RX, they're paying money and they don't have, yeah, RX, all right, RX over the counter, okay. But at the moment, depending on which state it is, it's either or, okay. At what age should a person be allowed to purchase marijuana? Okay, most people are in agreement to that. I got some that said 18, some say 21, some say, and I do have 30, yeah, Rebecca, there's just some people. Most people say 21. What penalties should be in place for illegal use of marijuana? Yeah, similar DUI if they get caught. Yeah, fines, intervention. Yeah, education. All right. So we have a lot of question marks here, right? And this is medically approved. So, all right. So regardless of the fact, yes, no, in between, let me give you a checklist. And what I'm going to do for y'all, I'll also, I'll get Aiden to do this. I've got a list of resources specific to CBD and hemp oil. If y'all are interested, I'll be glad to post them a Moodle for y'all, for FYI. I think it'd be helpful. I give them to all my practitioners, but I think it'd be helpful. They're easy reading. They're not overly, but they're got some very good magazines. But anyway, from that, here's a checklist of how to find a high quality CBD or hemp oil product, okay? And this is very specific. One, you need to look at the bottle and you want to, does it meet the following quality standards? Does it have a current good manufacturing practice certificate, CGMP from the FDA? Or does it have an organic certificate from European Union, Australia, Canada? Or does it have a National Science Foundation international certification? So you got 4 different ways to look at it, and all of them are very good. If you got 1 or 2, great. If it's got all 4, buy it. But the thing about it is you will find most of them don't have any of this. So, but these are legitimate credentialing bodies that are very, very stingy with giving their credential out, by the way. 2, does the company have an independent review adverse event reporting program? See, that's the biggest deal right there. See, if you give a medication right now, and I hear you, Eddie. Yeah, there's a lot of advertising going on. People don't know. But see, the thing about it is the liability. See, the thing that's going to come, and y'all know this already because y'all have already been in medical ethics liability. Some of you have been in cases. The attorneys are coming, and they're picking up on these companies. They got a lot of cash. They got a lot of places to put it. And they also got an awful lot of liability that I'm fixing to kind of explain to you. So you want to make sure that the company has an independent review for adverse effects. And some do, and a lot of them don't. Is the product certified organic or eco-farmed? And 4, have the company's products been lab tested to confirm THC levels of less than 0.3% with no pesticides or heavy metals? And let me tell y'all something. Let me tell all of you something, as I tell all the groups. This stuff is not cheap. You're not going to find a 1 ounce, 30 cc, 60 cc bottle of this stuff for $19.95. This stuff is going to cost you a lot of money because these credentials cost a lot of money, but they're safety based. But anyway, give you that. So, also in the world of pharmacy, I'm not surprised because there's been hysteria over many other compounds. Some have been allowed to continue to be on the market and some have not. The one that I recall is the most, I guess the most auspicious is DMSO. Y'all know what DMSO is? Oh, really? Really? Well, maybe I'm just older than y'all. Probably I am. I know I am. It is a veterinary liniment, but it's one of the best pain relievers when it comes to the inflammational processes in the joints that you've ever seen. But the problem was when it first came out, it was at strengths that were made for horses, not humans. And what happened is it absorbs through the skin. And of course, it went in and helped the pain, but also because people got so much relief from it, it also created liver disease. So DSMO, so y'all can look that up. It's a dimethyl sulfide oxide. Herbal compounds. We have all kinds of herbals in the marketplace that claim this, that, and the other. And I'm an herbalist, been an herbalist since I graduated from pharmacy school back in '74. And so the thing about it is one of those things that, you know, we need to know. And sugar substitutes, always a controversy about sugar. Botox, diet plans, anti-aging preps, vitamin supplements, potency products. So the hysteria over CBD and medical marijuana is not new. It's just another herbal product, another guise. This one had some legitimacy in that it was able to manage some very severe and very sick children from very serious seizure disorders, but it's similar, very similar. So, self-assessment question 12. Medical cannabinoids have many therapeutic uses that have FDA approval. True or false? B, A, B, A, B, A, B, A, B, A. Okay. It's B. The FDA, even though we have many states as of 17, and this has changed even since then, we probably only have about 4 states now that do not have some sort of marijuana law, either from prohibition, from decriminalization to allowing a medical marijuana, decriminalization, medical marijuana, legalization. There's all different types, but almost all 46 states out of 50. 23 have been identified as having CBD only laws. So a lot of this has changed. In Georgia, we've had all these changes over the last 3 years, from where they had nothing till we had everything. And that is one of the things that I will tell you. It's pretty interesting. And so we have a bigger, and you see this map, and again, this map changes from year to year because of the legislation, but you see almost 4 states now, only 4 states have no particular cannabis access program, even though I know Kansas and Nebraska both have laws that are going to be looked at in their legislature this year. So let's talk about it a minute. Here is your textbook. If I was going to make this a semester course, the health effects of cannabis and cannabinoids, it is from the National Academies of Science, Engineering, and Medicine. Most of you should be familiar with those and will be, but it's a free download. Now, if you buy the book, I think it's $75, but it is a free download from the National Academies. Wonderful book, about 440 pages. Only research that's in there is human-based and has no animal studies whatsoever. They wanted to make sure that this was as appropriate textbook as possible. And so all my prescribing physicians, I highly recommend this, and I recommend it to you. So here you go. So 440 pages, this can be a paperback. It's from the health effects, and so it's recommended several things. So when you look at it, they develop a consensus report in 2 primary sections, a section that would summarize what can be determined about health effects of marijuana use. Thank you, Carmen. Appreciate that. And a section of the report will summarize potential therapeutic uses. So we got current use and also therapeutic use, potential use. So hopefully you will get, I got a lot of benefit from it, and I've been looking at it. So here's the current regulation. Now, let me give you a little mini lecturette on DEA regulation. DEA Schedule 1 through 5. Y'all know what that is, right? Y'all familiar with that? Y'all know what the Controlled Substances Act is about? Okay, sure. So in this schedule, if you look at Schedule 1, we got marijuana, cannabis, along with heroin, LSD, peyote, methylphenidate, ecstasy, and bath salts. Got all that, right? And then Schedule 2, we got Vicodin and cocaine and all that. Schedule 3, 4, and 5. Okay, marijuana is in Schedule 1. Okay, so okay, what's the deal here, Mary? All right. So what does Schedule 1 really mean? Now, I'm doing this as a forensic pharmacist coming into your case where you've recommended some CBD medical cannabis product to a patient. She had an adverse drug effect and died. And so we're now in the middle of this forensic case. And so the first thing that typically they want me to do is what's the law? What does this mean if it does to drug A, drug B, or drug C? And I've done this So I'm going to do it the same way or similar way. So if you look at Title 21, Code Federal Regulation, blah, 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 1308.11 through 1308.5, and it says this is a schedule control substance. It says schedule substances in this schedule have no currently accepted medical use in the U.S., a lack of accepted safety for use under medical supervision, that's 2, and a high potential for abuse. Latest outcome request for rescheduling cannabis from Schedule 1 to Schedule 3, 4, and 5. On June 21st, 2011, the DEA concluded, now listen to me carefully, that there is no substantial evidence that cannabis should be removed from Schedule 1. This was reiterated again in June of 2017. So as of June 2017, the DEA says there is no substantial evidence that cannabis should be removed from Schedule 1. That is in the regulation. All right, y'all just hang on. Well, what about CBD? Okay, effective September 28, 2018, which is a year later, with the issuance of this final order, the acting administrator of the Drug Enforcement Administration places certain drug products that have been approved by the FDA and which contain CBD in Schedule 5 of the Controlled Substances Act. Specifically, this order places FDA, now listen to me, FDA approved drugs that contain CBD derived from cannabis no more than 0.1% tetrahydrocannabinols, THC, into Schedule 5. This action is required to satisfy the responsibility of the acting administrator under the Controlled Substances Act to place a drug in the schedule he deems most appropriate to carry out the United States obligations under what we call the Single Convention on Narcotic Drugs, 1961. Also consistent therewith, DEA is adding such drugs to the list of substances that may only be imported or exported pursuant to a permit. Okay, y'all got all that legal stuff? And I know a lot of you are in forensics, so you probably understand that. Now, but wait, they said, okay, we approved it. Oh, but wait, and 811D, Section 1 is relevant here because on June 25th, 2018, the Food and Drug Administration announced that it approved a drug that is subject to control under the Single Convention of the Controlled Substances Act, okay? Specifically, the FDA announced that it approved the drug Epidiolex for the treatment of seizures associated to 2 rare and severe forms of epilepsy, Lennox-Gastaut and syndrome and Devitt syndrome in patients 2 years of age and older. Now that Epidiolex has been approved by the FDA and it has a current accepted medical use and treatment in the United States for purposes of the Controlled Substances Act, accordingly, Epidiolex no longer meets the criteria for placement in Schedule 1 of the CSA. Okay, y'all got all that? Epidiolex came out. Okay, great, okay. But wait, we got more fine print. Oh no. Under international treaties, cannabis, cannabis resin, and extracts and tinctures of cannabis are listed in Schedule 1. The cannabis plant contains more than 100 cannabinoids. Among these is THC and CBD. Materials that contain THC and CBD extracted from the cannabis plant falls within the listing of extracts and tinctures of cannabis for the purposes of the Single Convention. Thus, such material, which includes, among other things, a drug product containing CBD extracted from the cannabis plant, is a Schedule 1 drug under the Single Convention. OTC CBD oils have not been approved for any medical use according to FDA guidelines, thus are regarded as Schedule 1 drugs. Do y'all hear that? So under the federal regulation, everything outside of Epidiolex in a CBD world is a Schedule 1. I don't care if it's over the counter, what it may be. I don't care what state it's in. It is considered under the federal law Schedule 1. Now, what does that propose? Now, the good news is, and some of y'all say, well, I've been recommending CBD for a year and blah, 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 blah. There are 2 amendments that were passed by Congress that are kind of backdoor amendments, but this is what it says. And I don't have those in the slide, but I'll tell you about them. It says, these 2 amendments says that the Department of Justice, which is the Federal Department of Justice, will not be allowed to expend any funds for any type of prosecution in states that have approved medical cannabinoids for whatever reason. And Rebecca, I'm answering your question. And that's the only reason. But the second question is, now listen to this. This is the forensic guy in me. What about malpractice? What does your malpractice carriers say, according to, if it be federal or state regulation, anyone providing a Schedule 1 drug or an unapproved medicine, herbal, whatever it may be called, and something happens inadvertently to that particular individual, are they going to cover your malpractice from that? And the answer to that is no. Yep, that's right, Jason. That's right. It's up to the court. That's right. But what I'm trying to tell people is, and I was with a physician yesterday in our state who is a pain doc, and he has been doing a great job using medical THC and medical CBD. And we had this discussion because in our state, you have to have the card. And if they have a card and they come to a physician, then the physician can technically recommend. He cannot write a prescription. He's not allowed to do that because they're tied to the DEA. See, the DEA says, and that's what ties all of this together to prescribing. It's the thing about it is, don't recommend, you can't recommend it, you can't prescribe it because DEA says it's listed in that ties to your DEA. Now, you guys, I don't know if y'all are going to have DEA numbers. I don't know. I don't know what you're going to have. But that's the whole thing. It is a difficult thing, but most people don't know this piece of it. And the reason now, listen to this. The reason it's not because it has psychoactive characteristics to it. It has to do to these international treaties up here. There's 157 of them. And cannabis is listed by that 1961 law as a schedule illicit drug. So for them to change it to a Schedule 2, guess what we have to do? We have to change the treaties. And what I've discovered, y'all, that is the primary reason that the DEA has not moved it from Schedule 1 to Schedule 2. There's been all kinds of wonders because in some of these countries that we have these treaties, we probably couldn't get a new treaty with them to start with. You understand? So anyway, I just thought that would be of some interest to y'all. So that is one of the things that forensically, it's important that you keep up with some of that. So here's the officially DEA cannabinol drug, approved drug, and this is in the law, in the regulation. A drug product in the finished dosage formulation has been approved by the FDA, contains blah, 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 which is the chemical name of Epidiolex. Schedule 5, Department of Justice Drug Enforcement rules said that they could move it from a 1 to a 5. And so in the government size, y'all, they have a CBD product that can be prescribed, even though it's $32,000 a year. Do you understand? So politically, they have done their due diligence. And that is why we have all these other products out here on the market that technically do not have approval, but people are using them mainly because of that price. So what does it mean? In the US, are physicians allowed to prescribe illegal, either by state or federal regulation medications? What does your medical liability carries require to cover malpractice? Under the current federal law, the only CBD product approved for use is Epidiolex per federal regulation. All other products are not approved and are considered Schedule 1. More regulation will be needed to appropriately correct this misstep of the federal regulators. Please seek legal advice prior to prescribing any product or recommending any product other than Epidiolex. Before recommending or prescribing any medical cannabinol, please check with your malpractice insurance carrier. And that is what I tell everybody. I don't care. I don't care. So the attorneys are getting into this, and as you go into my forensic kind of web page, as you look at those and you see the number of cases that are coming up as a result of CBD, as a result of medical THC and those types of things, they're starting to increase in number from that standpoint. And I think it will be from those cases, by the way, I think it'll be a class action against the federal government at some point that may change the regulation from a C1 to a C2. And that would be something to be helpful. All right. So let's talk about THC. Y'all ready to do that? Yay. All right. Here's the structure. It's delta-9 tetrahydrocannabinol, or delta-9 THC. Very few drugs, if any, have such tangled history as medicine. In fact, prejudice, superstition, emotionalism, and even ideology have managed to lead cannabis up and down to the ups and downs concerning both its therapeutic properties and its toxicological and dependence-inducing effects. E.A. Carlini said that in 2004, which is true. If we look at the stats, and we looked at this, we've got now 46 states in some form of legalization. It doesn't have much cross tolerance with other drugs, which is a good thing. It doesn't produce anesthesia, coma, or death in high doses, even though it's highly controversial. And so we've had multiple states make different things. It's been around thousands of years. We've used it. Prohibition is where actually marijuana became very popular in the U.S. As a result of less use of alcohol. But in 1937, the DuPonts decided they were threatened by the hemp industry, and it may be a better product. So the DuPonts went to the feds and said, we need to eliminate this drug from our culture. And so the Marijuana Tax Act made recreational use illegal and prevented physicians from prescribing marijuana back in the 30s. And the law has always been a part of the world, and it still is. But it has to do with nothing to do with abuse or anything, had to do with the politics of a very successful rope, a family that ran a very successful rope industry, and they changed the law. There are three types. Sativa, which is the type that we see. Indica, which is, it has THC in it, the hemp does. The Rudicus is grown in Northern Europe, and it's also now grown here. It is actually what we call the hemp, industrial hemp type. I'm reading a couple of books on this because I'm going to have to keep up with it. But they have well over 80 known cannabinoids. Habesh, the dried resins, it used to be the most potent. We now have dab, and we'll talk a little bit about that. Ganja is the dried material from the top of most of the plants, 5 to 8%. And marijuana, the leafy portion, used to be 2 to 5. And in the state of Georgia, and I don't know about y'all's state, I do a lot of work with the GBI here. The average potency of what we would call the regular street marijuana is 8.5%. And it's increasing based on the availability. The kinetics, you can take it orally. It can come in a solid or liquid form. Large dose needed to have some effects on inhalation. The liver will clear much of the THC. The effects are longer. Peak action of THC is about 1 to 2 hours. The overall action of it is 4 to 6 hours. Inhalation, rapid effects, reaches the brain within 30 seconds. Peak effects is within 30 to 60 minutes, last 2 to 4. and a subjective state of feeling, not so much euphoria, but experiences in the central nervous system can last up to 12 hours. When you look at kinetics, it is insoluble in water. It's absorbed almost 100% in all fatty tissue in the body, the brain being the primary organ of that. 25 to 30% may remain in the tissue for at least a week. It takes about 2 weeks for it to clear the tissue. It's metabolized predominantly by the liver, and it's excreted predominantly through the urine and feces. When it's detectable in the urine, and of course the drug screens have become more sensitive, frequent smokers, it can last up to 7 to 21 days. I've had positive urines on individuals smoking every day for 10 years. I've had drug screens up to 6 months be positive with a decreasing amount quantitatively. Infrequent smokers, 1 to 3 days. Daily users, 30 more days. And so it stays in the body for a prolonged period of time. Dynamics, it affects anandamide, and I'm hoping, and I don't know that I can do that, we found out a lot about anandamide and positive effects of anandamide and positive effects of 2-AG. But basically, anandamide is called the bliss molecule. The two receptors that are prominently involved with THC, we've learned a lot more about these. CB1, it has to do with central nervous system, memory, cognition, motor system, mood. And THC is a CB1 agonist. CB2 is more in the immune system. It's located outside of the central nervous system, mainly in the peripheral nervous system. THC antagonizes GABAergic responses selectively, so GABA1 or GABA5 or GABA7, and that's why we think it's a good pain medication, because GABA does transmit part of the pain cascade. It has dopaminergic agonism, so you also get euphoria, as well as GABAergic antagonism, so you get euphoria and pain relief. And so that's one of the things. It facilitates the release of serotonin. And as a result of that, it affects the endocannabinoid system. And that's why you have the issue with the munchies as a result of that. You can see the CBD1 receptors are all over the brain. The movement issue, people get clumsy with marijuana, cerebellum movement. They can't run. They get a heel to toe reflex slows down, so they don't run very well. So that's why the cops, when you're looking at live PD or something, when somebody's stoned on marijuana, they're pretty easy to find and run down within 50 feet because of the impairment of the movement. Appetite, we talked about. Hippocampus, initially you can increase learning capability, impair the memory with consistent use. It definitely is a stress reducer. Spinal cord definitely does help reduce peripheral sensations. It definitely works in the medulla with nausea and vomiting, and also it can, depending on concentration, affect higher cognitive function. So we have lots of uses for it. When we look at the CBD1, it's concentrated in that. We talked about that and reinforced the basal ganglia. CB2 primarily in the immune system, have a role in that. And the pharmacodynamics is the subtypes 3, 1, and 2, and that's kind of a picture of both of those as we see it. CB2 is a little different in how it works in the ligand and inhibition of CAMP in the cell, resulting in inhibition of transmission. But again, both are very, very complicated. The CB2 is mainly 2-AG. This is arachidonoglycerol, and a 2-AG is what I call it. It's the best way for me to say it. Whereas this one involves more anandamide. It does have 2-AG, CBD1. So this is the one that THC affects, and that's why they feel so blissful when people smoke THC. Mechanism of action is not fully understood. It's simply a G protein activity, changes certain sort of enzymes inside of the neuron, increases the voltage of both sodium and potassium channels, and has a pretty remarkable response. And that's why it has so much activity surrounding it there. What's the effects? Relaxation, augmented sense of humor, altered perception, time specifically. They think time slows down. Has some analgesic, depending on dose, it can create in high dose situations paranoia, panic, short-term memory, and impaired concentration. So we see that as a part of what we don't want. A lot of people have, for years, have talked about the amotivational syndrome. We think it's a part of that extended amygdala where it shuts things down. It's not really proven as clearly. It's come a long way, but it's not, the evidence is inconclusive whether or not does everybody experience amotivational syndrome. But people's symptoms are some apathy, lack of interest, passivity, but it could be based on personality too. So that is to be decided. Physiological effects are dilation of blood vessels in the whites of the eye, so you have bloodshot eyes, slow pupil reactions, decreased intraocular pressure. That's why we've looked at it for glaucoma, and even though we haven't approved it yet, but we think they may be a good product or several good products for the resistant glaucomas. Increased heart rate, increased blood pressure. Now, this is the problem that most people don't understand. The toxic effects, even at lower doses, almost has an immediate response on the cardiovascular system by increasing heart rate, sometimes up to 20%, increasing blood pressure. Systolic and dystolic can go up 10 to 20 points. When we was in Colorado evaluating 100 daily users for this public safety evaluation, where they'd smoke a joint, they'd stay a joint a day, and they'd smoke a joint, then they'd do driving simulators, and sort of for us to see coordination and measurements and all that the scientists were putting together. We found 2 that were at stroke levels during our physicals of the individuals that we had to forward to the hospital, and both of these individuals were under 40 years old. So this is an issue that is going to be more of a problem for people. And if you already have any kind of blood pressure or heart rate issues, you can see the risks that could come with that. Decreased movement, impaired coordination, initial bronchial dilation and constriction. So when you have the constriction in the bronchioles with THC, anyone that has breathing, COPD, asthma, whatever, then we're going to have some problems, especially if there's, and it also creates a slowing of the lung function. And also high doses can depress ovarian function. And we know that it has the possibility of decreasing sperm production by sometimes up to 50%. So we have those types of physiological effects. Sleep, suppressed REM, increased slow wave, does create drowsiness at low doses. It can interfere with sleep at high doses. It does decrease nausea and vomiting. It can be protective of brain injury. In fact, they have a medical cannabinol that's used in Europe for individuals who have had recent strokes. It becomes a neuroprotective. If they give it within 3 hours of the stroke, it almost protects the brain from any injury and any future injury as a result. It's a pretty remarkable drug, actually. It does create dry mouth, muscle weakness, body temperature fluctuations, and also dryness. So dizziness. And we'll see what we got. Withdrawal, you can have withdrawal with pretty heavy uses or daily uses over prolonged periods of time. They include sleep disturbance. You can have nausea, reduced appetite, irritability, restlessness with that. According to the DSM-5, this is your withdrawal syndrome. Jason said, how does that make sense with increased cardiovascular output in post-stroke patients? It doesn't, Jason, because we don't have the mechanism of action. If we don't know. The problem is what cannabinol is going to be used. You know, we're talking specifically about THC. We have CBDV. We have several other derivatives of CBD that are probably going to be very helpful with individuals with cardiac function. But THC, that's a good question. Because the cardiovascular events have been pretty well documented. So I would like to see the research on it. I mean, everything is open, you know, and everything can change. I'm not locked into this. I'm just going by what has been presented to me. So if there's information you have, please send it to me. I'll be more than happy to see what it is and what it looks like. But the primary issue with high dose will protect the brain post-stroke as long as we don't cause another. That's right. That's right. The stroke piece is great. The problem is the cardiac issue that may produce the stroke to start with. The blood pressure issue especially is the problem that we run into. And that's a dilemma that we're going to have to work out. That's why I want us to do something about it. I think we can do it. I think it can be resolved. But I would appreciate a new drug that would protect the brain from any further damage after a stroke occurs. For lots of reasons, and the situation I've had with a couple of folks recently would have been nice. Anyway, this is the withdrawal according to DSM-5, and that's what we will possibly see as we move forward. The use, multiple uses in the 90s and 2000, we've used it for cancer and AIDS. Now we got it for nausea. Now we may do it for glaucoma. Sovvevex is cannabis-derived medicine used for MS, which is a wonderful medication for MS, multiple reasons. And again, a lot of the products that could come from the plant, there's really no other product available that could be used. And that is why I've worked very hard to try to advocate to move this from a C1 to a C2 in order for us to really look at the whole plant and research it. We have the potential of lots of different medications that would be very helpful. And again, this is an older picture, but it is still very true. From glaucoma to MS to cerebral palsy to cancer pain of all types, phantom limb pain especially, palliative care for anorexia, antiviral caused by opioids, age-related illnesses, cancer, for cancer prevention, nausea, environment, cancer, chemotherapy, and asthma. You know, other things that we could really give some thought to that are not it. Most widely used illicit drug, third most common recreational above alcohol. Well, it's behind alcohol and tobacco in most studies. 8% of men. It's probably increased since I did this particular piece, but you see that it's across the board. We see in 04 no slide, UK percentage who use this is increased over time. And again, as legalization has moved forward, the adolescents begin to say, well, it's legal, we're going to use it. And so the schools are having even more of a problem with this type. And of course, now we have vaping. I really struggled with whether or not I was going to put the vaping piece in here about the death rate as a result of vaping having to do with the cannabis and THC metabolites that are involved into the vitamin E acetate individuals who have died from this. And so we're going to do it. All right. One of the most common drugs people seek treatment for is cannabis. Stigma can be attached. It's not attached as much as other drugs, interestingly enough, from my perspective. So people are more willing to get treatment. And so as you look at the different numbers from some of these studies, 07, 08, and we could look at it in experience, we have had about a 27% increase in cannabis-related admissions in over 2016, 2017. We think that may be contributed to legalization, but we don't know for sure. Well, should we use it for chronic pain? Is it a delight or dilemma? Again, Marinol is available. It's a synthetic THC. It comes in gelatin capsules, 2.5, 5, 10. Usually only relieves select patients for a limited period of time, limits several therapeutic compounds found in natural cannabis. It's shown to be more psychoactive than natural cannabis, believe it or not, and it's also more expensive than natural cannabis until the dispensaries came out, and now natural cannabis seems to be more expensive if you go through the medical marijuana in a lot of states.
Sorry, I'm having trouble hearing you.
Oh, that's my watch on. All right. So in medical marijuana, the most commonly abused illicit drug, we talked about it. It comes in various shapes, forms, flowers, seeds, leaves, sativa, and it's usually smoked. Can be used in a pipe, smoked in blunts. Y'all know that. It is a Schedule 1. We've made that very clear. Illegal to possess under federal law in all 50 states. That has changed because of the government cannot spend any money, federal government can't spend any money with any kind of state that has legalization involved. And so we have all of that. University of Mississippi has grown marijuana since 1968. And it's been funded by the National Institute of Drug Abuse. It was first originally called in 1968, a lot of people don't know this, the Nature Institute of Drug Abuse. That little known fact gets out, it'll be a... So anyway, if y'all have ever gone to Oxford, Mississippi, and seen the farm down there, we have, they grow 1 to 6.5 acres of marijuana. It is used in all research. When that marijuana is used up, even up into today, what they do is they take confiscated, and most of their marijuana is about 3.5%. They take confiscated marijuana from these various drug busts and are able to produce a product that's about 3.5%, and they make it into cigarettes. And we even have folks that are still, we only have about 20 that's still on this list, but they will send them about 200 marijuana cigarettes a month. And it's, the U.S. government started the Compassionate Investment New Drug Program, which supplies 300 marijuana cigarettes per month to seriously ill patients approved in the program. It was shut down in 91, but 7 of those patients as of 06. We now have up to 20 now that have increased because they've legalized it. So the government is actually providing to some small portion of patients with certain types of chronic illnesses their own marijuana cigarette. So, and they've been doing that since the late 60s. And marijuana extracts were one of 3 of the most prescribed medicines in the United States in the 90s. We've done that. CBD. All right, what I'm going to do is I'm going to stop here for a short break, and I'll come back in 5 minutes. Y'all can let me know when you're back if y'all need another break. And we'll wrap up with this with CBD, okay? Any questions y'all have, let me know. I'll be back in 5. Thanks. All right, y'all ready to go? I am. Yeah, I'm ready. I see I got 30 in the house, so let's talk about CBD. And we've already talked about the legal piece of it, but we'll talk about the practical piece of it and see what this may give you the difference between THC and CBD, which, there's a lot of difference actually. It's a non-psychoactive. In other words, it doesn't create euphoria. In fact, as we will get into it, it's derived from hemp and the cannabis plant. You've been able to find it in health food stores and other shops: pills, tinctures, salves, creams, chocolate bars, honey sticks, energy bars, sleep masks, coffee, among other things. And it is a huge boom. We estimate it will be a $10 billion industry in the next 3 years. And it's exploding. It's simply exploding every day. There's all types of processes. The oil extracts, if it be THC or CBD, they are being illegally promoted as cancer cures, and the oils have not been evaluated in any clinical trial for anti-cancer activity or safety. It is used in cancer chemotherapy for nausea and vomiting, but there's far from that from being any kind of cure. But people are making those claims because CBD is a potential inhibitor of certain cytochrome P450 enzymes. Yes, Rebecca, the pharmacies are definitely, but you have to understand, I live in pharmacy, and what we're interested in and what pharmacies are interested in, I'll be honest with you, is money. People wouldn't be in the business unless it's for money. Are a lot of pharmacists trained to understand CBD for anxious pets? According to my vet school, which is across the street from me, the answer to that is no. And according to my vet pharmacist, who is very well versed in the herbal preparations and other things for all types of small animals, he said, be very careful because of the potential problems with the liver. But anyway, the enzymes, they're here. They can create toxicities and decrease effectiveness in therapies. And it's one of those things that as we look into this and look into it more, and this probably will become my full-time job once I decide to retire from the university, just to keep up with this, because there's stuff into it moving very fast. In fact, some of you will probably be wanting to consult with me at some point when you get into a state and you're looking at this and you're using CBD to treat anxiety disorders. You'll want to know the A, B, C, D, E, F, G. And I'm excited about that, to be honest with you. I'm really looking forward to, having some better products, but it has to be done the right way, and so that's the structure. It's a little different from that. It is, again, primarily has been documented to be used for seizure disorders, very specific seizure disorders. But it has also had, based on, we haven't studied it here, but they have studied it in Europe. They have studied it in Australia and other parts of the world. It has been looked at for analgesic, acute and chronic pain. They are looking for it as a management of psychosis. Now hear me when I say that. It's used for psychosis as a result of high THC consumption. That is what the antipsychotic component is. Use a THC or THC derivative as an antipsychotic medication for high THC psychosis. Anxiolytic, don't know. Again, the book that I recommended to you a while ago really gives you some insight into some of that. And I think I've maybe got some of those studies in this slide set. Anti-cancer for pain and nausea, but it's not all pain. As an anti-inflammatory, it's suggested, but again, we don't know for sure if that's the case. It does act via the endocannabinol system as it's defined. It does not activate the CB1 or CB2 receptors, or does it mimic 2-AG, which is anandamide or any of the other endocannabinols. We think it interacts with the endocannabinol system indirectly. So what does that mean? It means that this is an entirely different product from THC. Question: how high? A recent forensic claim in THC increased propensity for psychotic break. It appears he was already psychotic at the time of use, however. True. But high dose, we have seen non-psychotic individuals based on high dose consumption have psychotic episodes been reported. And that's been throughout the literature for a number of years. The percentage, we don't know for sure, but let me tell you this. I don't know what a 25 to 30% THC concentration will do to the brain. I will know that it's going to create a lot of adverse drug effects, and one that seems to be on the top of the hit parade when we get to high dose is psychosis. So that's my best guess. And what I'm saying is anything above 20% is considered high dose to me, but because of tolerance and what people are using now, we've had people who have been, in fact, I've had graduate PhD students come in because we had a university and they've been vaporizing, using vaporizers to increase their potency, and they've got probably potencies up 35, 40%. Every one of them, there's 3 of them, every one of them had psychotic episodes. So it's one of those things. As Joey said, a frequency in my class also seems to make sure more prone to psychotic disorder in general than having drug induced. That's right. It is one of the, and we're not real sure why. Is it because it overstimulates the dopamine, which, you know, psychosis is about a dopaminergic response? Is it because it alters? I think it's because it alters the pathways of dopamine. But anyway, one of the things that we're looking at is to use this type of derivative, because if you look at the pharmacology and the physiology of it, it's entirely different. So what receptors does it bind to? What receptors does CBD bind to? Well, it has a number of receptors. It's unclear whether or not it's an endogenous ligand, and y'all know what endogenous ligands are, of how it crosses that membrane, except for the chemical messages related to its various receptors. So is it serotonin-based? Is it opioid-based? That's, again, a question. So when we look at receptors, and again, this is where the research needs to be a part of, these are some of the obvious choices by the scientist. You got the 5-HT1A, and if it does affect that, we could use it as an anxiolytic or antidepressant, maybe. Adenosine receptors, agonist, because of adenosine and anxiety GABAergic response, adrenaline response, anxiolytic, maybe. The one that most people don't know about is the TRPV1, which has to do with the pain cascade and whether or not it could be used as an anesthesia, analgesic. Mu and delta receptors, whether or not we could be used as an analgesic. The PPAR, which is another enzyme involved in certain types of cancers, if we could produce an anti-cancer drug from it. And again, the GPR555, which has just been discovered, they don't know whether or not it would have something to do with the psychotropic, antidepressant, anxiety, antipsychotic, etc. So we don't know. And how are we going to find out? No one in this country is going to pay for any of this type of sophisticated research unless there's federal dollars. And where do you get federal dollars? You get them from federal grants. But if you've got an illicit, unless it's very, very understood, and there's some limited research going on with marijuana today, but it's very limited. the big boys, the pharmaceutical companies, are not going to look at it. And so until we get that, then it's going to be a problem. So let's look at some of the efficacy research. The cannabis was common in people with chronic non-cancer pain who have been prescribed opioids. They wanted to know if it's an opioid sparing possible medication, but found in this study, no evidence that cannabis use improved patient outcomes. People who used cannabis had a greater pain and lower self-efficacy in managing pain, and there was no evidence that cannabis use reduced pain severity or interfere or exerted an opioid sparing effect on this particular study. It was a 4-year prospective study. As cannabis use for medical purposes increased globally, that a large, well-designed clinical trial, which include people with complex comorbidities, are conducted to determine efficacy in cannabis for non-cancer pain patients, which is true. So here's one that says no. All right, that's one that says no. Then we have one that says yes. Latest cannabinol effective meta-analysis of 119 non-pain trials, 5 of which are exclusive to cancer pain, found that THC had an approximate equivalency to codeine. Now, when we compare opioids and pain relief, codeine, as I've told you earlier, has a helix of what? 1. It's very similar to aspirin. And we got cancer pain. So how effective would codeine be in treating most cancer pain? Well, not very good. So this study says it's got an equivalent to codeine. Jason said, I read an article in New Mexico suggests chronic marijuana use increased experience of pain post-surgery and which required more prescription. Yes, sir. And that has to do, Jason, I would strongly suggest, to the pain relieving cascade that's already been depleted because you depleted the endorphin system, the normal cascade. And as I read more out of, and I'm getting the bibliography from this journal article from National G, and going to look at some of that cascade a little closer, I would anticipate that is one of the reasons. So yeah, I anticipate that heavy marijuana use could create increased post-surgical pain that would be very difficult to manage at higher doses because of tolerance. Even though they claim no cross tolerance, if you understand what I'm saying. More recent meta-analysis, 11 randomized controlled trials in chronic neuropathic pain demonstrated an insignificant overall change in pain scores, resulting in a weak recommendation for the use of cannabinoids. Okay, all right. But then we had a meta-analysis of the effects of cannabinoids on cancer pain in 43 random controlled trials revealed a beneficial benefit in favor of cannabinoids, but patients were highly likely to experience significant CNS and gastrointestinal side effects from that use. And that is from cannabinoids and cancer pain and the American Society of Cancer Oncology and Oncology in August of 2018. Good article. What about efficacy and reporting in the management of any kind of medical cannabis? What kind of dose? What's the dose I need to give? Well, this study said, in knowledge of safety, he said that in the study, the result that all medical cannabis used in patients in this particular study used a standardized controlled herbal cannabis product with a reliable THC potency at 12.5%. 12.5%. The suggestion that adverse effects of medical cannabis are modest and comparably quantitatively and qualitatively with prescription cannabinoids. The results suggest that cannabis of an average dose of 2.5 grams per day in current cannabis users may be safe as a part of a carefully monitored pain management program when conventional treatments have been considered medically inappropriate or inadequate. Okay, so, all right, so we got another study there. It is truly a tale of two drugs, y'all. Delta-9 THC and CBD. As I told you, THC directs is an agonist on the cannabinol receptors, primarily CB1, but does affect CB2. CBD behaves differently, has psychoactive effects, sedation, anxiolytic through the effects of less than THC without any kind of inebriation or euphoria. Growers have become skilled at growing plants with very high resin contents with differing THC and CBD ratios. And then as we look at, they have become concentrated, skilled at concentrate and isolate these chemicals, crystal THC and crystal CBD. So what you got now on the market, hear me, you have a crystalline THC product and a crystalline CBD product. That's the core. That's the core. And so let me see what I got here. So here is the question. What's in a dose? No, I think Eddie's from Colorado, I think you said. So according to Colorado's medical equivalency in portion and dosage, and this is a regulation again, for 1 ounce of flower bud with a 17.1% THC content, you can get more than 425 doses of THC equal to 10 milligrams a dose. And that calculates into 2,100 doses per 5 ounce, et cetera. And it tells you how many you can get out of 8 pounds versus how many doses you can get out of 200 pounds. But what I'm trying to say here, what they have arbitrarily decided is that when we're going to give medical THC, the dose, if it be the dose that would come in a leaf form, the dose that would come in a capsule form, the dose that would come in a tablet form, or the dose that would come in a chewable form will be equivalent to 10 milligrams of THC. That's one dose. So if you got a chronic pain patient and it says you need to take 30 milligrams THC every day to treat your pain, here you go. But you have to understand he's taking 10 milligrams of a 17+% THC content, which is extremely high. So for a long time, the amount of medical marijuana for a year in a patient was about a pound of bud or leaf. More recently, the average for medical marijuana users is about 1 to 2 ounces per month. Colorado considers 10 milligrams THC a standardized dose, which is really moving forward. Because when I look at that, and it's a 17% THC compound, and being a pharmacist, and I know that's contained in 10 milligrams, then I compare it to what is also already on the market. And then you can compare prices and safety and all of that. So when I compare that to Marinol, which is synthetic THC, it would be compared to about 5 milligrams, similar to a 10 milligram THC. So if you buy it as a THC, that's kind of organic, let's call it from the plant, versus a synthetic from Marinol, it's about twice the dose. Amounts allowed under various laws for cultivation and possession have been overly generous to many patients. So the dosing is inconsistent. That's where I'm at. I could not, as I asked you in the beginning when we started this section, what would be the standard dose for someone who needed it for seizure disorder? What would be the standard dose of someone who had an acute pain situation or chronic pain? What is that? And none of that has been decided, y'all. From a liability standpoint, for me to be able to give a medication with no dosing guidelines and no dosing parameters would be a disaster. So I can't mess with it. I can't touch it. Regardless of what the state law says, what the federal law says, I can't give an answer. And I'm supposed to be trained to be a medication expert. So when we look at CBD in medical and industrial hemp, which is always a question, CBD oil is defined as marijuana under the Controlled Substances Act, derived from the resins of the plant. Marijuana means all the parts of the plant, whether or not it's growing or not, the seeds thereof, the resin extracted from many of the parts of the plant.
Such terms do not include the mature stalks of the plant, fiber produced from such stalks, oil or cake made from the seeds of such plants, or any other compound manufactured salt derivative mixture preparation of such mature stalks except for the resin extracted thereof, fiber, oil, or cake, or sterilized seed of such plant which is incapable of germination. It is confusing to understand what is industrial hemp and what is not. Joy said, is this why I won't consider it for my who has epilepsy, THC, or CBD for your dog? Joy, if it was me between the difference between THC and CBD, CBD would be what I would give. It's a more specific and it's got more literature if you're going to use it for your pup. If it's my pup and I had the decision to make and I have CBD is what I would tell you to do. I don't have as much information on seizure disorder and THC as I do CBD and seizure disorder. So that's my 2 cents. Industrial hemp is subject to a federal program under the Agriculture Act of 2014. It says industrial hemp is actually marijuana that contains less than 0.3% THC by dry weight. Can be used for research. Industrial hemp may also be grown by an institution of higher education or state Department of Agriculture for purpose of research conducted under agricultural pilot program or other agricultural academic research. And if the growing or cultivating industrial hemp is allowed under the laws of the state where the cultivation and research occurs. Now, hear me when I say that. If the law has said, as it has said in the state of Georgia, you'll be allowed to cultivate industrial plant under agricultural protocols. And the protocol require them to be inside, they have certain security, they got to have DNA testing, and blah, 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 blah. I mean, a pretty sophisticated list. In order for you to cultivate it, you may be able then to produce it to either sell to academic, research, or private institutions who are going to produce CBD. And so that is one of the things about when it says low THC, does that mean CBD? No, it just means that it has to be less than 0.3%. And that's what you normally will find, usually find in the industrial hemp hybrids of the plant of marijuana. So again, it gets to be where you do it. CBD is not industrial hemp though. It can be, it can come from an industrial hemp plant, but you also can extract CBD from a traditional marijuana plant. This gets to be confusing, I know. But again, people use, and the reason I'm telling you all this is I talked to my med and pharmacy students about it the other day. The industry intentionally makes it confusing. So when you read something on the bottle, for instance, if Joy was going to use a CBD to treat her pup for seizures, and it said industrial hemp CBD, or is this CBD oil that contains less than 0.3% THC, people don't know what that means. They just think it's all the same. And what I'm going to tell you, it is not. To produce a truly industrial CBD from industrial hemp is extremely expensive. I'm working on a PowerPoint now on the extraction components from the factory standpoint of what that looks like. So when the laws are written, and this is in the Federal Register, this is out of the U.S. Secretary of Agriculture, people are going to come to y'all and ask about CBD, and they're going to bring you a little bottle. It's going to have a dropper. You're going to look at it. It's going to have hardly any information. And what are you going to tell them? Well, unless it's got certain parameters, I say, buyer beware. I can't really tell you anything about this. The only way that I'm going to know what this may contain is to have it analyzed. And I'll tell you about my analyzed. Send it to a couple of labs, send them off. We've had about 18 different samples over the last year and a half. And they've come back, 17 have all come back with higher than THC amounts than posted. Some is twice as high, some is 4 times as high. And then I've had a couple come back with no CBD whatsoever. So I can't tell you what's in the bottle. It may have it. In pharmacy, we're not allowed to use anything except manufacturer's labels. How much does it cost to analyze? It runs anywhere from $1 to $200, depending on the lab, and depending on how many tests you want and how much, what type of analysis you want. They have different types of levels of analysis. So, and if y'all are interested in that, I'll try to put y'all together some information on several different labs that you may be interested in looking at. So, but anyway, it is a major concern because of what I'm just trying to explain to you. And we also have the approved Epidiolex, and it is there. It is available, but it's very expensive. But it is absolutely what it says it is. And here's some of the products, and these are some of the products from the advertising websites, from some of the bottles that were given to me that I looked up. And we had all kinds of edibles and all kinds of drops and all kinds of hemp oil. See, 20% hemp oil. What the hell does that mean? What does that mean? And then you got Receptor Plus, and you got, 1,000 milligrams of CBD, blah, blah. What does that mean? It's just crazy. It's crazy. I'm just telling you. So we have manufactured pharmaceuticals. So we got the Marinol, which most people are familiar, synthetic THC, nausea, vomiting, appetite stimulant. It eases neuropathic pain. Molecules very complicated. Researchers have estimated only 10 to 20% of Marinol in each capsule actually reaches its target in the body. And a lot of that has to do with how it's formulated. If you look at it, it's formulated in sesame seed oil. Some people are allergic to sesame seed oil. It's insoluble in water. So it's hard for this particular medication to be absorbed. And when you only got a 10 milligram dose or 5 milligram dose, it's hard to get a therapeutic dose high enough. And you're taking an oral tablet versus usually what most people do is an inhalation. You take leaf marijuana, you inhale it so your concentration is higher. So you can kind of get some sense of why people don't use it. Now, Saldose was approved. It's the liquid formulation. So this is your, if you don't know this is your legal, and I'll go back to Joy and what she asked me. This is your legal THC oil, Joy. It's called Saldose. It's put out by Lakewood Labs. It is used for anorexia, having to do with HIV/AIDS, nausea, vomiting, chemotherapy. But it is the THC formulated, synthetic. It's THC oil. So you've got a Epidiolex, which is a organic CBD oil. You got Saldose, which is a synthetic THC oil. So according to the federal government, they have oral preparations, both on the THC side and the CBD side, that can be prescribed by physicians. And why do they want to deal with the rest of this? And that's a pretty interesting position that they put themselves in. And then everybody's out. And a lot of people can't. It has to do with the expense and how much these things may cost. Sestimet, now if we want to go one more step, is Nabilone. It's a man-made synthetic drug which activates strictly on the CBD1 receptor. It is an antiemetic, nausea and vomiting. It replicates healing properties of THC, but does not actually contain constituents found in the cannabis place because it is a synthetic. Now, it lacks the ability to tap into the entourage effect, which means the cascade of going from THC to THCB, THCD, et cetera, et cetera. But this is another product that is available that people can use as another synthetic THC. Now it comes in tablets and capsules. So government says now we also have Marinol tablets. We have, which are synthetic THC tablets. We have synthetic THC capsules, Sestamet. We've got a synthetic THC oil, and we've got an organic CBD oil. So what else do you want? So I'm just trying to say to you, this is one of the reasons that it's so difficult to get all this other stuff on the market, because the DEA don't want to change a whole lot, and they've already approved certain medications, even though the indications are not there. Okay, so here's Epidiolex. It's 100 milligrams per meal orally. It comes as a 10 cc or 20 cc bottle. Comes in 100 cc's. Usually they got a 200 cc bottle now, but it's very expensive. I am not sure that insurance has approved it on their formularies yet. It may, but I don't know that yet. I need to find that out. And then we got another one, Sativix. It's made GW Labs. It's for neuropathic and spasticity of MS, and it's only approved in Canada, as I've mentioned to you before. So the thing about it is, we've got to, I'm hoping that this one will come this way. I'm hoping that we will be able to get this into the US market here very shortly, but I'm not sure. A lot of politics around that. Dextroamphetamine, which is a neuroprotective. This is the one I was telling you about. It's a synthetic psychotropic cannabinol, which blocks MMDA. It's by far, it's the one that's available primarily in Europe. It's not available here. But again, it is pharmaceutically grade. It's got research behind it. And so the thing about it is, it would be nice to be able to have this option for people who may need that type of medication. Remember, BAT is the one that we've had out, and then they took off the market, and then they're deciding whether or not they're going to put it back on. It is the one that Sanofi put together as an anti-obesity medication. It's also been used as again, this is another one that they think may be used for high dose THC psychosis. They're looking at that. So, you know, we've got that. And so it would be nice to look at and consider that. They had some issues with this, with the liver initially. So they've, you know, it's been withdrawn from the market at the moment. So they're trying to resubmit and try to get it reapproved. So what about the palliative effects? What is, you know, some research on the nausea and vomiting? Evidence is low. We have, in this particular study, there was inadequate sample size. HIV were superior in both weight and gain and appetite, but not for nausea and vomiting. So you could actually use cannabis to increase appetite and increase weight gain. Cancer patients, no difference between cannabis and placebo in improving caloric intake. So what we're finding out is that depending on the population, and this is the one thing that I'll tell you, it has a lot to do with what the disease states are. Here's another one in the opioid sparing preclinical. This is mainly animal trials. They showed some evidence of synergistic effects of actually where they could give a cannabinol and reduce the dose of the opioid. That's what we mean by opioid sparing. The ED, effective dose of morphine, was 3 times, almost over 3.5 times lower when administered with Delta 9 THC. So if we could give them a synthetic THC, we could reduce the risk of respiratory depression with morphine, which is common, y'all, which is very common because we use it so much. But again, this is in animal studies. 10 clinical studies of varying quality, half provided moderate to high quality evidence and half were low and low quality. And some of these studies are pretty pitiful. Only the volume low, N equals 3. Now you can imagine, N equals 3 showed opioid sparing. So I've got 3 patients in the study and they indicate that yes, it was opioid sparing. 2 low qualities where there was no placebo at all showed some improvement of pain, improvement sleep. And so, but none of the 3 high quality placebo controlled trials showed any kind of improvement of pain or opioid sparing. So how about adverse drug effects? Try to get through this before we shut it out for the evening. Memory. Memory, again, is persistence of learning over time, storage, retrieval. Encoding, you've got to encode the information in the memory system in order to get it to storage, and then from storage, it's got to be retrieved. So you have sensory input, you got sensory memory, and sensory memory, unattended information is lost, as most of us have probably done with this lecture today, because we're tired of looking at screens or listening to screens or whatever, and unattended information. So if you don't go back and revisit some of this, you may not recall it, or I won't. You have to pay attention if you do and that goes into a short-term memory system. And even with that, with maintenance rehearsal, we have to put it in the short-term memory. And of course, the older we get, it seems like the more that we have to do this. And so unrehearsed information is lost. And once we get it in the short-term memory, we got to get it in the long-term memory. And that's where the encoding. Encoding starts after maintenance rehearsal, starts with short-term memory, encodes into long-term memory, and then we can regurgitate it back to short-term memory at some point if we need it. Some information may be lost over time. Maintenance rehearsal is required. Now where THC and the cannabinoids will come in is begin to impair this first part of short-term memory where the short cycle, there's no long-term memory established. And if you don't have a long-term memory established, you're not able to encode it in long-term memory. And so the retrieval, and so what we have is a short attention span and really a diminishment in the capability of learning new things. And of course, has to do with long-term memory, which if you can't get it into short-term memory, there really is no particular long-term memory that you have to deal with. So it's not there. If we look at the Canadian study on adverse drug effects, and this is made by the Canadian Medical Association, pretty interesting study, by the way, included Savax, Marinol, Nabilone, and leaf marijuana. There were 321 articles in the study, which is pretty comprehensive. There was 4779 adverse effects reports, 4,500, a little over 45 reported as non-serious, and 164 reported as serious. There was 15 deaths reported. Not all the studies reported adverse drug effects, though. The more serious adverse drug effects included respiration, renal, cardiac, and infectious disease. So we had 4,700, almost 4,800 reports, 164 were serious, and 15 deaths, which is probably not as significant as it may sound, but it's there. All right, when we look at the issue of cannabis on most levels, and we don't know this yet about CBD, but with THC we do, withdrawal. If we use a moderate dose oil-based product for a period of 6 to 8 weeks, the risk of a cannabis withdrawal becomes more significant. And these are the signs, according to the research, of the diagnostic criteria of cannabis withdrawal that was done in 12. And so you can kind of see craving, sleep difficulty, insomnia, anxiousness, that change in appetite, sadness, irritability, anger, those types of things, increase, decrease appetite. So you will see that. The main issue is sleep difficulties and the feelings of irritability and aggressiveness and the feeling of anxiousness. So the more common ones are those 5 there that you can see. If we look at the withdrawal course, the time that it takes in order for us to recover from a withdrawal, according to this particular study, the insomnia comes pretty quickly, decreased appetite, and it can occur within the first couple of days, and it can last 3 weeks. The irritability and restlessness and anxiety doesn't start to about day 5, usually. And the anger and aggressiveness starts about day 6, and all of these can last at least 3 weeks, which is people are not aware that they last that long or can occur. And again, this is dose related. So if they're having higher doses, you can extend this into weeks. And we've seen folks actually have into months. And so the withdrawal component is pretty substantial. If I look at the dilemma of opioids and cataminols, when you use opioids for chronic pain syndromes, they're not recommended unless very close supervision is applied to patient care. I'm a pain management guy, and I did this, and I've given this out many times. Most people don't know that if, and I'll give this to y'all too. You can take, and y'all listen to me when I say this, I have no particular stock in either one of these products I'm fixing to mention to you, but you can take a trade name 650 Tylenol, which is basically what they call arthritis strength, and one of those, and one Aleve 220. That gives you the same pain relief as about a hydrocodone 7.5. And what I've done with a lot of my opioid dependent individuals who cannot, in fact, because of tolerance reason, cannot usually take, you give one of those, they give one of each every 12 hours. And I've got about 80, I guess now 85% of those individuals not using anything else except that. The thing you have to give with it, though, if they have the chronicity of pain, of course, they're under supervision of appropriate pain management too. So there's being some procedures and some other things being done. But you have to give them a PPI or H2 antagonist. You either give them, a Pepcid or a Zantac or something in order that you don't have such disturbance in the stomach. But other than that, most of them are doing quite well. Because you start giving these opioids for long-term chronic pain syndromes, unless they're very rare, very closely supervised, a lot of them can run into trouble. Increased dosages for opioids for cancer survivors is on the rise. In fact, I've had 4 cancer survivors come into the clinic with opioid use disorder as a result of continuing opioids even after the cancer had gone into remission. So that's one of the reasons I was been able to train a lot of oncologists recently to understand what that means. Present time, the latest medical studies indicate that neither THC or CBD preparations provide adequate pain reduction for severe chronic non-cancer or cancer pain. So more studies required. Much more research is required before an appropriate substitution of medical cataminols for opioids, which a lot of people are jumping on, and y'all know that. Y'all hear that. Some of y'all mentioned that today. And most experts will support the placebo effect of cataminols in place of opioids. I'll be the first to tell you, it may not have therapeutically an effect, but the cataminol in and of itself, it'd be CBD or whatever the product may be, may have a great placebo effect. And I'm definitely an advocate of some of that. So that is at least what we think. The vaping component, I'm going to throw this quickly. I just wanted y'all to see the Juul and all the preparations. We've had 60 deaths, 27 states. The reason I bring this up is a majority of these were male, 2/3 were between 18 to 34. 37 were between 18 to 21%. They've all reported having a history of e-cigarette product use. So most of them were kind of veterans of this. The latest findings from the investigation of lung injury associate e-cigarette use, vaping, and suggested products containing THC play a role in the outbreak. So the CDC, and this is their latest information I have, over the last 30 days have reviewed 2,600 patients. 82% of them reported THC containing products. 34% reported exclusive use of THC containing products. 57% reported using nicotine containing products, and 13% reported exclusive use of nicotine containing products. So they have got kind of a profile of where these individuals are. The specific chemicals causing the associated use are still, all of those are unknown, but there's no single product been linked until recently, although vitamin E acetate has been linked to the national outbreak of e-cigarette, vaping, and product use associated lung injury, EVALA. And it's one of those things. More information will be needed, and that's why all reports. So if y'all got people having to come in and they're vaping and they're having some problems, please have that in that report to the CDC, and they've got that information available on their website. What it looks like is when people come in, they suffer from respiratory symptoms, including coughing, shortness of breath, chest pains, difficulty in breathing. They may suffer nausea, vomiting, diarrhea, fatigue, abdominal pain, fever, weight loss, and other common symptoms. On the lung x-ray, the lungs may be inflamed as if a pathogen infected them, but the doctors look at, they find no common bacterial viral source, and they really can't see anything. Again, patients are only vaping in common, but no specific problems except for this E-acetate recently. Without a true diagnosis, vaping is difficult to treat. Current treatment includes steroids to reduce the inflammation. All patients will need oxygen to help them breathe, usually through breathing tubes, possible ventilators, and some in the worst case even need support from machines that oxygenate the blood outside the body. And other medical concerns include microscopic pollutants, equipment explosions, and cardiotoxicity. So it's one of those things. All my clients vape and use energy drinks. It's like detox starter kit. There you go, Joy. Welcome to another set of unbelievable medical components and problems that people do not take care of themselves. So you're just inhaling a vapor, and users load a liquid solution into a device, and there's different types of devices like that. They got the cartridges, they got electronic cigarettes, they got e-pens, they got vape pipes, they got all kinds, vaporizers, all kinds of things. And you can look at all different types, and a lot of this is really based on economics and what they want to look at, but you do, all of them are electronic and it can be charged. They got some very sophisticated and very expensive ones. Some people take these, but again, they all basically work on the same principle. The Juul doesn't really have a lot of vapor that comes out. It is just inhaled. And here's the problem is the e-liquid, e-juice. Now the FDA generally views as both PG and VG as safe in foods, drugs, and cosmetics, but there's no significant scientific studies done on what the impact inhaling on a short or long-term basis may be. It's not always clear what is in the e-liquid. See, you can take some of this stuff on the label in foods and it's safe. We don't know what happens to it when it's heated and when it's put into a vaporization and concentrated. This is one of the things that I will tell you that has to, really be considered. So you got all these flavoring agents, all these different products containing all these drugs. And most people think it's just water vapor. That's what they've been sold. A lot of kids think it's water vapor. Oh, it's just water. It's not smoke. It's just water vapor. Well, it contains all of this. And from this, we have all of these different byproducts. And what do you think of what's in the vapor today? When you inhale it, you look at it, nicotine, propylene glycol, formaldehyde, glycerin, blah, 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 blah. All types of things that create problems down the road. Popcorn lung, I'll mention that just quickly because our time's getting up and I know y'all ready to go. It's called bronchitis oblivians. It was discovered a decade ago in the microwave popcorn industry, where factory workers who were flavoring, butter flavored, putting flavors in popcorn, coffee, caramel, and dairy products, made it tasty, but because when they put that food source into these machines that would vaporize it and heat it, many of the manufacturers, many of the employees of the manufacturers developed an irreversible lung disease. As a result, the popcorn industry simply removed diacetyl from all of their products, but people are still being exposed to it, not through food flavorings as worksite hazards, but through e-vapor. They've got the same product that was found out 10 years ago, had multiple lawsuits, creating all these irreversible lung diseases, is currently in e-vapors. And here you go. Over 1,000 flavoring agents that may contain this particular product. And these are all the things that it includes that are in red. So this is out of the National Institute of Occupational Safety report of 3 months ago. That's what popcorn lung looks like. Joyce said, saw a documentary and they basically concluded that you should use all different kinds of juice to reduce the chance of the one being bad for you. It doesn't sound promising. Well, in result, y'all, you damage the lung tissue at the bottom of the lung first, and it goes up and it will curl up very similar to the shriveling up of the lung tissue. And once this starts, it doesn't stop. That's why it calls bronchitis obliterans. Once the process stops, it don't stop. It will continue to that lung is completely annihilated. And that's what most people don't know. And so here's the nicotine, high concentrations, 300%. Health effects, of course, of nicotine. Most of you realize neurotoxin alters the brain. And this is why the different websites people can use. If you have people interested, here you go. Here's you some information. There's your references. And ladies and gentlemen, believe it or not, it's about 7 o'clock. And we are done for today. Are there any questions? Well, you're welcome, Carmen. I'm as tired as you are. I'm as tired as you are. We got to do it again.
Hey, Dr. Norton.
Yes, ma'am.
I thought I'd just ask you on audio. It's easier. I was just curious on the case study questions on the ASAM criteria.
Yeah.
I had looked over some of the cases, and granted, you know, this was last night, but I was looking at the different levels, treatment recommendation levels, and I could see how like arguments could be made for one level versus another, kind of based on your clinical bent.
Mm-hmm.
And I wasn't sure, and I know you're grading those, so I was just curious, you know, what we should be keeping in mind when we're doing that case conceptualization, like,
well, this is
conservative, or is it just our actual opinion? Or
what I want you to do, the experience of the case studies is this. You put down which level you think would be appropriate and the reason. And what I'm going to do is, there's no right or wrong in these cases, by the way. This is for experience. This is a part of the whole curriculum. But we will discuss them. What I'm going to do is have you get in. Y'all going to fill them out. You're going to come, and then I'm going to show you the answer, or at least what I considered the answer. But it doesn't matter if you think it's a level 3-7, tell me the reason why you think it's a 3-7. If you think it's a 2-5, you tell me. What I'm trying to do with a lot of you is get you familiar with the criteria and the placement criteria. That's basically what the purpose of it is. So that's my answer.
okay,
As I told you, you're welcome. As I told y'all, based on what this whole course and how it's designed, is an experiential course. They wanted it, and we had to do this 2 years ago to add the cases. Well, I had cases last year, but they really wasn't as strong as I want. And these are all really, to be honest, they've been modified, but they're all they're all real cases. And so I want to kind of see your input of what you see the criteria looks like, and where you would place them in treatment and the reason behind that. So, and from that, we should have a pretty good discussion. So, and that'll be what we'll do tomorrow afternoon.
so we do all 10 tonight? Is that the plan?
Huh?
Do we do all 10 cases tonight?
Yes, you do all 10. Because I'm probably going to chaw on certain ones, because I've got certain ones participating, and part of this is as I look at it from the class, is participation of talking about the case and interacting and then asking questions. Why wasn't this way? And that helps me help you understand what the process may be. But yes. Okay. All right. Anything else? Are we to do this before class tomorrow? Brady, it would help. What I was planning on doing, I don't know how much time it's going to take. I've got 3 more classifications to cover in the morning. Then I go to treatment aspects, and then before then it's past noon. So I'm really not sure how long I'm going to have to cover the cases. What I was planning on doing is give you some class time, if you hadn't really completed all of them, to give you some class time where I could be here to answer questions about the case if you didn't understand it. It is due, you are to submit it by Monday, but we're going to discuss it tomorrow. You got it? Yes, that is what that's, and that way you can at least formulate the correct process. And this is for, I know some of you have done this and you can do it in your sleep. So you've covered them and it's no big deal. The reason I gave you 10 cases is for the diversity of the cases and also to talk about it. But once we get it done, we'll be done. And then you submit it and then I'll put it in there and we'll grade it and we'll go from there. How's that? Okay. Where are the case studies? They're on Moodle under the assignments. Eddie, that's where they are. Have you gone to Moodle? Are you on Moodle? All right. Y'all got my email. Text me, email me. If you need something before we start class in the morning, if there's questions, let me know. Y'all have been great. Thank you for your patience and your tolerance of trying to let me get through this technology. And y'all have a great evening and a great afternoon, wherever you may be. And we'll see you in the morning. Good night. Thank you very much. Thank you.